Okay, so the first thing is y'all have to talk loud because unfortunately I drive my husband crazy. I can't hear.
Where is the test going to be located? Where do we need to show it?
I think it's in the book. It says where. Yeah, I'm not sure but I would imagine it's in these rooms here and not remote. Yeah. Okay. Yeah. Let me get one thing. Let me get my timer. Okay, so I was 1 minute too much the last time. I don't know if I can do that well. I'm gonna see if I can do it this time. I'm gonna sit over here a little bit. I almost want to bring tables up to the middle. Can we bring some of the tables and just put them, rather than them all the way in the back? I want everybody to come up closer. Go on that side and I'll get this side. Here, I'll get one in and you get the other.
Is there going to be enough room?
Yeah, I think so. We can kind of bring it up. Just in the second row there. There we go. Yeah.
So
There we go.
Yeah.
This is how it is in the big meeting room. I don't want everybody.
Let me grab it.
You got it?
Yeah.
If you want to sit in the back, you can, but.
And then do you want to bring another table up?
Yeah, hang on a second. Oh, you got the chair. Thank you. Perfect. Yes, I want everybody to be able to hear me and see me. Come on in. Come on in. Heather. Heather, you can practice wearing it. You can practice wearing it. It'll bug the. Here, can you get it? Turn it around the other way. I kept clanking on the microphone. It's like, okay. All right, girlfriend. You're set. I would give you the ring, but I can't get it off. You're so cute. Oh. Okay, you ready? You want me to back it up the one slide?
I've been recording for the last 5 minutes.
I'm sorry?
I've been recording for the last 5 minutes longer.
Okay. So you heard me give Heather the necklace? Okay, I'm gonna go ahead and get started. And it's very casual for you all. If you can edit some of this out. If you need to leave, you can leave. You can stay as long as you need to, or you can stay the entire time because I'm going to be here. So a little bit about me. I am from Jacksonville, Florida, and I started out in nursing in the early 80s and started in cardiac and open heart recovery and then moved to plastic surgery and have been in it ever since 83. Started out with fillers when it was collagen and wondered why anybody would want a needle stuck in their face. But of course I was young and didn't have any wrinkles at that time, so now I totally understand. And I've actually worked as a medical science liaison since 2007 for Bioform and MERS and then Galderma, Saniva, and now I'm currently a consultant for Prolinium, and I also train for Sinclair Pharma on Silhouette Instalift. So I have had a while on the private practice side, but also on the industry side. So hopefully that'll help some of the information that I share with you. So here's a little rundown of the schedule that we're going to be going through. And we have a bio break in about 2 hours. So we're going to start with the aesthetic consultation, then dermal fillers and volume enhancers, botulinum toxin type A. Then and Kybella, then when we come back from the break, it's going to be lasers and light therapy, sclerotherapy, clinical skincare, and then hopefully there'll be time for Q&A. The CANS exam is going to have 150 test questions, and they're going to be multiple choice. Time yourself, make sure that you go through the test. If you're not sure about an answer, just kind of put a mark there, but don't spend too much time on it because it is a timed exam. It's 4 hours, and 55% of it is going to be aesthetic injectables, 30% is light and lasers and energy-based therapies, and then 15% is clinical skincare. The aesthetic consultation is the first part we're going to go over. And a huge part of it, as we discussed, is going to be on body dysmorphic disorder, which I'm going to refer to as BDD instead of just saying out the entire name. So an important, very important part on your assessment is when you bring the patient in to have an intake questionnaire, and then also ask the patient, because a lot of times they don't put everything on the questionnaire. When you start asking questions, it may spark their memory. I know I've found out patients a lot of times, for whatever reason, decide they don't need to tell me everything. Make sure they know that this is HIPAA and that it's a medical procedure. It's not, even though it's aesthetic, that it's a medical procedure. It's very important that they share all that information with you. Their secrets stay in their chart. It's not something that's going to be public knowledge. But if they don't tell you, and this is something that I give my patient as an example, if they've had previous surgeries on their face, their anatomy has changed, and it makes a huge difference when I go to do, especially fillers. So you need to not only know their past medical history, but you also need to know past surgical history. You also need to know if they've ever had angioedema or if they've ever had an anaphylactic reaction. But in general, are they allergic to latex or lidocaine? Have they ever had herpetic breakouts? And this is important for lip injections, lasers, and chemical peels. Do they have any medical implants? It's actually contraindicated for any Ulthera treatments, and I'm sure there's going to be new machines coming out in the future. We were hearing about a few today. So you definitely need to make sure that if they have any implants that they let you know. And this says just metal implants, but I'm going to actually include any kind of implants, cheek implants, chin implants, or anything, because it does make a difference when you go to do fillers. If they've got implants in there and you come in with a filler, you can potentially stimulate a biofilm infection and start a cascade of issues. So always ask about implants. Keloid scarring. In the core, the fourth core, Bellafill is referred to as Artefill, but on the exam it's been updated to Bellafill. So if you see Bellafill on the exam, it's the same thing as Artefill. There are a few chemical changes, difference in the product, but for the test purposes, the same. In their instructions for use, it actually tells you to avoid using this product on anybody with keloid scarring. You also need to know about permanent makeup, if they're pregnant or nursing, bleeding disorders, or they're a smoker. So again, I just mentioned that previous surgeries make a difference, not only in the changes in the anatomy, but scar tissue. Scar tissue is a huge, difficult thing when you're doing, especially like cannulas or putting in threads, just trying to get through that scar tissue makes it really hard. Plus, one thing a lot of people don't think about is when you've done fillers and the patient's had them several times, you've actually made scar tissue in there. You stimulate collagen, but you also make a little bit of scar tissue. And when you're putting in a filler, it's not unusual to see a filler go in a totally different direction of where you'd planned it to go. It's going to take the path of least resistance. So knowing what their aesthetic history is and if they've had any facial surgeries is really important. Also, if the patient's ever had lymphedema or any adhesions or wound healing problems, that's going to be a real big red flag for you to need to know. Their medications, if they're on blood thinners, anticoagulants, and antiplatelets, obviously bruising, swelling, sticking a needle in them. We're not doing surgery, so they're not going to hemorrhage, but they definitely are going to have bleeding issues. And it does slow your procedure down, and they need to know that it's going to cause potentially a hematoma, which takes a lot longer to resolve and can really distort your outcome. And many times, especially with pre-periosteal injections, if you hit the periosteum too hard and you cause a hematoma, you need to stop your treatment at that point because you'll be chasing your tail. You're not sure, is it the hematoma that's made the correction or is it the filler? Aminoglycosides are extremely important to know for patients on if they're going to be getting any neuromodulators. They both interfere with the neuromuscular transmission, and you need to know that. Any of them that end in mycin are a pretty good clue that it's aminoglycoside. And then also immunosuppressants you need to be aware of. So you also need to know their routine skin care. If they're taking retinoids, lightening agents like hydroquinone, if they've recently had any microneedling or microdermabrasion or chemical peels, and then their tanning history. This is probably the one that gets me. Patients sometimes won't tell you that they go in a tanning bed because now it's taboo, but they still do. So you need to ask about tanning beds. I think a lot of them are outlawed in places, but I know people where I live, they have them in their own home. Also, the medication, the injection now, that I guess it's still not, I think it comes into the US bootleg, but I do know that people are getting them, and it increases the melanin production in the body. So if you look at somebody's Fitzpatrick type and you just ask them their genetics, it's not going to tell you everything. You need to dig deep. When was the last time you were outside exercising? Do you do a lot of outside stuff, or did you just go on a cruise, or were you sitting out, especially the beginning of spring? I live in Florida, so if I'm really, really pale, but after about 2 weeks of being outside, I start getting more tan. but that tan doesn't show. That's from the exposure that I had a couple of weeks ago. Those melanocytes are a little bit lower and developing, so you just need to find out what their activities are, because it's going to have a huge outcome on the laser testing, and actually PIH on some people too. And do you have any medical conditions? ALS, scleroderma, rheumatoid disease, they'll have an outcome on their procedures too. We discussed allergies a little bit ago, but here are several fillers that actually do come without lidocaine in case somebody has a lidocaine allergy. And there's debates on, is there a true lidocaine allergy? I don't want to find out. I mean, I'm not testing them. If they tell me they have one, I'm not going to get into a debate. I have surgeons tell me people are not allergic to lidocaine. But this is a cosmetic procedure, so I'm not going to take the risk. Restylane, Juvederm Ultra, and Ultra Plus, the touch-up syringe, the 0.4, and then Revanesse, Versa, and Bellatero. They won't be on your test. They weren't launched when the test was written, but I just want you to know if you need one in your practice, those are also available. Then animal-based ingredients, they could have allergies to. The hyaluronidase Vitrace, I don't know many people that use that anymore, but if you do get that one, you need to do a patch test with them. And if they have an allergy to any, to sheep, then you need to make sure that you don't use that on them. They'll have an anaphylactic. The other is the amphidase. I don't think that's available in the US anymore. I think, is it available in Canada? Because I know in Canada, we don't have any of the Canadian girls today. They don't have Hylenex in Canada. And Hylenex is the one that's basically the synthetic. But amphidase is a bovine base, as well as Belafil, which I just mentioned a little while ago. So with Dysport, patients that have an allergy to milk protein, not a lactose intolerance, but a milk protein, the true allergy to that, they should not get Dysport. And the little asterisk next to the amphidase and the Belafil, alpha-gal syndrome is a new syndrome, and it's not going to be on your test, but it's something that the manufacturers don't warn you about. But it's I think there's been articles published on it for the past 3 or 4 years. It's from a tick bite, a Lone Star tick, and you would think it comes from Texas, but the East Coast is really heavy, not just with Lyme disease, but also with this new alpha-gal syndrome. And it's an allergy to the protein in red beef, and they will not have the allergic symptoms right away. It may take several hours that they have them. So you need to be aware of anything that's got a bovine base in it if they have an alpha-gal. Skin typing, be aware, again, like I said, the different Fitzpatrick types, you need to know those, and they are actually on the exam, and they're listed in your the fourth core. Know them. And you're going to need to understand, they're going to ask you a question. I'm sure there's going to be questions on PIH. So understand which Fitzpatrick level they start having issues with PIH. And then what would you use for PIH? What would you do to avoid it before any laser treatments or anything? The Glogau Wrinkle Assessment Score, and I kind of chuckle about this because everybody's like, huh? So when you see new products approved, this is the scale that they use when they do the clinical trials. And nowadays with clinical trials, they have to see an improvement of two points. So if a patient comes in group 1, they have to move to group 3 to be considered clinically effective. So that's why we want you to know this. And if you're looking at products, or you're looking at the study or on the test, and there may be a question of, the patient is in a group 1, and they're Fitzpatrick 2, and they have thin skin. When we get into the dermal fillers, which filler would you use? So just understand, this is really pretty basic, and the biggest thing I can tell you to help remember this is 2 is from hyperkinetic, and 3 is from static. So there's none hyperkinetic, static, and then just wrinkles throughout. So psychological warning signs are body dysmorphic disorder, depression, OCD, anxiety, addiction, overuses, and overtreated. And I have the magnifier on there, but I think that there's probably a lot of patients that don't even need the magnifier to see those lips on some, or cheeks or sometimes. So it's our responsibility when a patient wants to get overtreated and they come in and they have body dysmorphic, we need to identify them in our mind. So I'm going to kind of go over some warning flags for you. The Mayo Clinic has defined it as a person that cannot stop thinking about a flaw in their appearance. And that flaw can either be minor or imagined. And these patients are totally consumed with pointing out facial or body imperfections. And they think that the non-surgical treatments are going to drastically change their life. And for more novice injectors or providers, you're going to get the patient that's going to come in and they're going to be telling you that they've been to several providers and nobody can help them. And don't think you're going to help them either, because they're usually the ones that's one of the first flags. The others are, ask them, on average, how many times, how many hours in the day do you think about your face? This treatment will completely change my life is something that they will tell you, and I can tell you that I have heard that. I've definitely heard that. Some of them aren't going to be as obvious, so you're going to have the red flags, but they're not likely going to be happy with that. Even if you fix it, they're going to fixate on the next thing. So if you are not equipped to deal with that type of a personality disorder, either refer them out or talk to your medical director about it, because they definitely are just going to go from one to the next. And I can tell you from my experience, it's not, once you are confident in your skill set and you are okay with saying no, life is a whole lot easier. And those patients get told no. I know my front desk tells me when there's someone, they're like, you're not going to want to treat her. That's kind of our code. So I already know that she set off red flags at the front desk, which you all will see that. Another one is those patients are usually disrespectful to your staff. They may not be to you, but they are to your staff. And a lot of times they will be to you too, but you're just not going to please them. So again, like I said, they've never been satisfied with other providers, and they expect perfection, not just improvement. And that's probably, for me, when I'm listening for clues, that's my real dead giveaway. And then most of the ones that I can think back to, they might smile, but they definitely avoid eye contact. It's really weird. I can tell you that every one of them that I can think of, they just kind of have this stare, and they want to hold a mirror. So if you don't want them to really stay in your office a long time, do not give them a mirror, because they won't leave. And they definitely have unrealistic expectations. So always, always, always take before and after photos. Those are your best, for your education, but also patients forget what they look like before you did anything on them. So many times, they'll come in and say, well, I spend all this money and I don't even see any difference. And when you pull out the picture, happens time and time and time again, they're like, whoa. So make sure you have those before and afters. And then also the informed consent. I can't stress this one enough to you. Make sure that your consent forms are specific to the treatment, and make sure that if there's anything on and off label on that procedure, which is majority of what we do, don't just tell them it's off label. You tell them what off label means, And the consultations, for me, I can tell you when I have a new patient, it's a 45-minute consultation. And I want to make sure that they are fully informed. When one of them, they get shocked, and we'll get to when we go through the neuromodulators, is how many times they've had neuromodulators, but nobody ever told them there was a black box warning on it. And they look at me, they're like, really? So to be responsible and to give an informed consent, you have to tell what the procedure is, you have to explain it, you have to tell what the other options are too, which one of the options is do nothing. So you have to give them all of the information so that they can make the fully informed consent. And most lawsuits now are ending up being in the informed consent side. Patients are saying, I would have never done that if they had told me that was going to happen afterwards. And they'll pick apart your consent. On most of my consent forms, and it takes forever, but I've seen other people get caught up in having a very brief consent. There's a little line next to several points. They have to initial each one of those. And the first thing they say to me is, I don't need to read this. And I tell them, if you don't read this, don't tell me, because I'm going to read it to you. So I actually have all mine printed out on a paper, because we use electronic. And they're printed and then they're laminated. And I have them all on a clipboard, and I hand each one to them. And they get time. And it gives me time to prep, get everything out and all. But if they tell me, I'm not going to read this, I'm like, sorry, but I'm going to read it to you then. I even keep readers in my room for my patients that say, I didn't bring my glasses. I'm like, oh, no problem, here you go. So dermal fillers and volume enhancers. And the reason we are saying volume enhancers now is because all fillers are not put in the dermis. Lots of them are below the dermis, and so we're going to refer to them as volume enhancers too. The skin anatomy. We know you all know the skin anatomy, but I'm just going to go through it briefly and point out just a couple of things that definitely pay attention to. And it's kind of a good review, because with the fillers, you're going to be in different depths. So the epidermis is the stratum corneum, granulosum, spinosum, and basal. And then the dermis is where the work gets done. It's where the blood vessels, nerve endings, the collagen is produced, the elastin, and hyaluronic acid. And hyaluronic acid is going to be your keyword throughout this test in many ways. And then below the dermis is the subcutaneous, and then the muscles and the bone. So the epidermis is the outside dead layer of the skin with the dead keratinocytes, and then the stratus corneum. That's the one where we work with a lot of the times, and it's the outermost layer. And it's really the protective barrier. The other two obviously have a function, but it's not really an indication in the exam. But the stratum basal is where the basal cells maintain the epidermis, and they are continually renewing the cell and the population in the cells in the area, and they work their way up until they're sloughed off as the epidermis. The dermis, again, is the supporting layer, and the blood vessels, the hair follicles are down in there, the nerve endings. But the biggest thing I want you to remember is the elastin and hyaluronic acid. And the hyaluronic serves as a scaffold for collagen and elastin, and it attracts water, and it keeps the skin plump and moisturized. As we age, the skin changes, and the biggest thing you'll see is the epidermis thinning. Just without even doing a huge inspection, you can see the changes where it's thinning out. When you're seeing your patients and you're doing fillers, you'll be able to see their vessels more. Take into consideration that if a patient has a lot thinner skin, certain fillers aren't going to work on them. You'll be able to see the color of the filler, like Radiesse. If they've got paper thin skin, you'll see the white through their skin. Certain suture thread lifts, if their skin's too thin, you're going to be able to see those threads or either the cones on them. So you need to really pay attention to the thinning skin. They've got decreased sweat and oil glands, so their skin's a lot more dry. So that means when you're doing laser treatments or their skin's super fragile. and it's due to the loss of collagen and elastin fibers that leads to the rhytids and the sagging skin. So the fat pads, I mentioned the article the other day by Rohrer, R-O-H-R-E-R, and Pessa on the anatomy of the fat pads, facial fat pads. And this goes back to that discovery and that discussion. And you can see going through aging changes how much you lose fat in your face and the areas where you're losing it. And the superficial loss is you end up getting with more of the facial wrinkles and folds. And then the deeper fat is what gives you the contours. And when you lose that fat and the volume loss in that area, you tend to get more changes in the contours and flattening out of the cheek and the jowl formation. So the deep fat is really what sculpts the face, and the superficial skin is more, or the superficial fat is what's going to give you those lines. Muscle changes are obvious in especially the glabellar area, partially because they're losing fat, but also because the hyperkinetic movement in those muscles over the years, they get a lot thicker. And if you think of the Cro-Magnon back in the Dark Ages, where they had the really thick, heavy area in the frontal area, that muscle is a lot more developed in that area. The bone changes are probably the discovery by Dr. Lambros, and he did a huge paper on it, and a lot of people have just kind of continued the study on it, but it points back to Dr. Lambros' first discussions were the changes in the orbit, and where the arrows are on that far right screen of the skull, the medial, superior, and the inferior lateral of the orbit is what really changes, and that's where you start seeing the hooding of the upper lid and kind of the hollowing and drop of the brow. And then the nasal cavity, you can see it widens out, and the maxilla kind of turns in and flattens, and then also the mandible changes. So you're going to end up seeing saggy eyes. The nose appears larger just because there's not the support in there, because the face kind of starts, they say, caving in somewhat, and the flattening of the cheeks. And then the mandible gives you changes not only in the jawline but also in the chin. The FDA-approved dermal fillers in the United States are considered medical devices. When we get into the neuromodulators, they're actually prescription drugs. So these are in a similar category as a chest tube or a catheter. So they're a device. And they're used to helping create a smoother and fuller appearance in the face, including nasolabial folds, cheeks and lips, and for increasing the volume on the back of the hands. Those are the FDA approvals. Obviously, we use them in other areas, but that's the indication, and that's the wording for most of them. The classifications are based on the duration, which is short-term, long-lasting, and permanent, and then also on the physical characteristics, which are absorbable and non-absorbable, and then non-particulate, which is hyaluronic acid, and then you also have particulate, which is calcium hydroxyl apatite, and then polylactic acid, and polymethacrylate, which the calcium hydroxyl apatite is Radiesse, PLLA is Sculptra, and then PMMA is Belafil. If you don't know or understand rheology, it can be confusing in the beginning. And back when I first started doing fillers, that was not even a topic that was discussed because we just had collagen. And then when we got Restylane, it really wasn't discussed. Once mid-face volumization started, people really started to realize, whoa, we better make sure we pick the right one, because if we use one that the consistency of it is too thick, we're going to see ridges, and we're going to have to use a whole lot of one that's not got a higher G prime. So if you've not understood what G prime is, I'm going to kind of give you the basics. But if you think of Jell-O, and you can compare Jell-O with pudding, that may help you kind of understand the difference. So the G prime is the measure of the elasticity, and it's called the storage modulus. And the higher the deformation rate, the more solid the material, and the higher the G prime. So higher cross-linking of HAs can make a product harder, and it also is supposedly supposed to metabolize a lot slower. When we get into the Juvederm products, you'll see that some of them are a little more cross-linked than the others. And it doesn't always apply to all of them because the Restylane products, they're all cross-linked the same. There's just a little bit change in the manufacturing process. So this isn't on everything, it's for some of the HAs. But the amount of the cross-linking that's added is going to have an effect on it. So here's a G prime of the FDA approved fillers, and the one on the left, the Radiesse, is the particulate, and it's the highest, but that's actually without lidocaine added. If they add lidocaine to it, it drops down to the Restylane. You can see where it says a 0.3, how much it drops down when you add, and it's actually 0.3, and it makes a huge difference adding that in there. So we don't have Restylane sub-Q here, so I don't know why that's on there, but we don't have Restylane sub-Q. We have Perlane, which is now Restylane Lift, and then regular Restylane. So you can see Perlane, the Restylane Lift, and Radiesse mixed with lidocaine are almost identical. They're very similar. And then you go down to the Juvederm Ultra. This is not going to be on the test, so don't worry about this, but I wanted to give you this term because it's usually discussed with G prime. This is G double prime, which is the elastic modulus, and it measures viscosity. And you're going to hear the words cohesivity from one of the manufacturers. That's not a scientific word, that's their word that they make up, but viscosity is. So if you see viscosity in a product, it's talking about how thin is it or how fluid-like. And what that really means is it has to do with how does it integrate into the tissue, how well does it spread into the tissue. So if you're going to be treating fine lines and you want a product that has really good viscosity, then you would look for something that has a higher G double prime. Okay, so the hyaluronic acids is the first category of the fillers that we're going to discuss, and they're basically just a polysaccharide sugar, and they naturally occur in the dermis, and their job is to maintain hydration due to its hydrophilic nature, and you need to know that. That's huge. Not only do you have it in your skin naturally, which keeps your skin plump, and as we age we lose the hyaluronic acid. It's in the fillers used, and that's how they plump us up, but it does not. When we used to do mesotherapy years ago, they would mix hyaluronic acid in it as a carrier to get it in, but it was not cross-linked, so it only lasts for 24 hours. So to give the hyaluronic acid duration, they actually cross-link it, and we'll get into the cross-linking in just a second, but the base of the hyaluronic acids are bacterial versus animal. And you'll see when we go in, there was one that used to be out years ago. It was made from a rooster comb, and it's no longer out. But all of them now come from, I don't want to say the same batch, but they have the same base in them. They're bacterial, and they're from the Streptococcus equi. And so if anybody has an allergy to that, then you need to be aware of that. There are some new fillers that are going to be coming out, some HAs, and they are neither bacterial or animal. I think they're plant-based, and they should be coming in the next, I want to say within the next year or two. Some of them are out in Europe, but they're quite interesting. I think one of them was like a plant algae, and there was one that was in development. MERS was doing several years ago, but they had too many problems with it and they scratched it. But there's a couple of other companies that'll be coming soon. So the use of the BDDE is used to bind the polysaccharide, the chains of sugars. and it's to create a larger molecule. And the cross-linking makes it more resistant to degradation by the body's own hyaluronidase. And the duration, again, and the persistence of the HA is based on the cross-linking. The more cross-linked, the harder and the longer it's going to last. So here is a lightly cross-linked. So this would be more like Juvederm Ultra. And they may refer to it as the Hyalocross product that is got a 6th degree of cross-linking. So that would describe Juvederm Ultra. So that's kind of the light chains in it. They also have the longer chains, and there's, I think it's, the Juvederm family is more with the long and the short chains, and then the Vicross family actually has more of the shorter chains. But you can see that when it's a short chain, the little red in there, it's not very cross-linked, so it's soft. And then on the bottom, the one with a lot more of the red, the BDDE, it has a lot more, because they're longer chains, it's got a lot more cross-linking, so it's a little bit harder product. So again, less cross-linking, it's a softer product, and then the lot of cross-linking just means that it's going to be firmer. So the first FDA-approved one that we're going to talk about is Belotero Balance from MERS, and it was FDA-approved in 2011, and its indication is for the correction of moderate to severe facial wrinkles and folds like the NLF. I think in the IFU it says such as. So that means it's not only the nasolabial fold, it means similar to. So that's how they get away with doing the oral comms and marionette lines. They call it the smile line complex, so they are allowed to kind of add that in it. When we get to some of the other fillers, they may be specific and they say only the nasolabial fold. This one again doesn't contain lidocaine, and it's for injection to the mid to deep dermis, and it's got 22.5 milligrams of hyaluronic acid per cc. Juvederm Ultra XC was FDA approved in 2006, and it's made by the Hyalocross technology. And again, it's got a moderate to severe facial wrinkles, such as nasolabial folds. And then they got lip approval in 2015. There's 24 milligrams of hyaluronic acid per milliliter, and it's to be injected in the mid-dermis if it's for the nasolabial folds area and the cutaneous area. Juvederm Ultra Plus XC was approved in 2006. And again, it has the moderate to severe facial wrinkles like the nasolabial, but it's for the deeper dermis. And again, like I was saying, this one is more cross-linked. It's got an 8-degree cross-linking, so it means it's harder, but it also has 24 milligrams. So remember that the Juvederm and Juvederm Plus have 24 milligrams. Mm-hmm. Yep. When they make the syringes, they actually put what they call raw HA. It's not cross-linked. So sometimes you'll read that what is the amount of cross-linked hyaluronic acid. That just means that they added maybe a little bit in there to lubricate to be able to get the HA out of the syringe. So that's not going to be on the test, but if you ever hear that, that's what it is. Now, the Vicross technology, this one is 20 milligrams Voluma, and it has short and long chains, and this one has more long chains, and I believe the Hyalocross has more short chains. And this was FDA approved in 2013, and it is intended for mid-face volumization at the supraperiosteal or subcutaneous level. And again, it's got 20 milligrams of hyaluronic acid per cc. Now we're going to get into the Galderma products. And the first one is Restylane, and it was approved in 2003. It was the first hyaluronic acid that was approved in the U.S. And they received the first initial approval for, again, the nasolabial folds, moderate to severe facial wrinkles and folds. And they got in 2011 an FDA approval for submucosal implantation for lip augmentation for patients over 21 years of age. And then again, they got the Restylane with lidocaine in 2012. And all the Restylane products have 20 milligrams of hyaluronic acid per cc. The difference in these is the way that they actually are made. After they mix up all the hyaluronic acid, they take screens and it's called sieving. And depending on the diameter between the little squares in the sheet, when they sieve it, that's how they get you'll see they call it biphasic. Galderma does not like to be called biphasic. That was kind of something that another company made up and it got stuck on them. But they're not particulate product, but their hyaluronic acid is sieved into particles based on the depth of the injection. So Restylane Silk, which is for lips, is a smaller particle than, say, Perlane or Restylane Lift. So Restylane Lift, again, was formerly Perlane, and the FDA approved Perlane in 2007 for moderate to severe facial wrinkles and folds like nasolabial fold. Then they got mid-face approval in July of 2015, and it's improved to go deep dermis and subcutaneous and or supraperiosteal. And again, like I said, the particulate gel is the largest particle for the Restylane brand as far as the sieved ones. They have other ones, and this isn't on the test. They have the Restylane Refine and Define. Those are not sieved. Those are similar to the Vicross, the long and the short chains, but they were called Emerville in Europe. But when they brought them to the U.S., for sake of saving confusion, they renamed them all with the Restylane name and gave them the different names. So this one is also, again, sieved, and it's got the 20 milligrams. And like I said, it says biphasic for the test. And then Restylane Silk was approved in 2014 for lip augmentation and perioral wrinkles in patients over the age of 24. So this one doesn't have just lip indication. It also has to do with the perioral soft tissue in the subcutaneous tissue. And 20 milligrams of HA, and this is the one with the smallest particle size. And the treatment volume should not exceed 1.5 cc's in the lips or 1 cc in the perioral area. Now we're going to get into the particulate products. Radiesse, which is calcium hydroxyl apatite by MERS. It was FDA approved in 2006, and the company at that time was Bioform. And they changed names, I think, in 2010 to MERS. And then they continued on to get a hand approval in 2015. And it is the only filler that is considered a filler and a biostimulator, and that's because of the gel carrier, the carboxymethyl cellulose. That actually is 70% of the product. When it is injected, it is a volumizer. As it metabolizes over about 3 months, the calcium microspheres stimulate collagen, so that's why it is a filler and a biostimulator. And you need to know it's actually termed a bioactivator on the test. They not only have approval for cosmetic, but they also have an approval for HIV lipoatrophy. and it is to be used in the deep dermis and the subcutaneous junction. And they also have a lidocaine and a non-lidocaine version. So the one on the left is the non-lidocaine and the plus is the lidocaine version. And I think if you get the one on the left, you can still get it with the mixing kit, and you can add lidocaine if you want it, or you can use it without. Sculptra PLLA is by Galderma, and it was approved in 2009. The original company was Sanofi, and they're owned by Sinclair in the United Kingdom, and Galderma is just a distributor. It's made abroad. It's not made here in the U.S. And the indication is for the correction of facial lipoatrophy with HIV patients and for shallow to deep nasolabial fold contour deficiencies and other facial wrinkles. So this kind of gives them a leeway to do panfacial injections. It's to be injected in the deep dermis or at the deep dermis sub-Q junction. And know this too, that it takes multiple treatments, and you should probably wait between every 4 to 6 weeks to do them. And again, this is another bioactivator, but it is not a filler, it's just a bioactivator because the water is absorbed. You mix this with sterile water, and the water is gone in approximately 24 hours, and then the patient's own collagen will be stimulated, and then they'll see the correction, which is why they need to do multiple treatments. Belafil PMMA, again, like I said, I think in the book they'll refer to it as Artefil, but on the test it's Belafil. And it was FDA approved in 2006 for nasolabial fold only. This is the one that does not have such as facial lines and folds. They only have FDA approval for nasolabial folds. But then they got an approval in 2015 for acne scars, and those are actually distendable. So there's different types of scars, boxcar, rolling. This is for ones if you can pull them and efface it, that's what they're FDA approved for. And it's to be injected in the deep dermis. What we talked about allergies before, if they have a bovine allergy, the collagen that is in this is bovine based, so they should not have this if they have a history of bovine allergies, and they also should not get it if they have a history of keloid formation or hypertrophic scarring, which we discussed earlier, but you need to know that. So dermal filler and volume enhancers clinical outcomes are based on a couple of things, but a lot of times you need to know, does the patient have any problems with swelling? Do they have lymphedema? Do they have, we talked about this morning, we heard Dr. Surek talk about the festoonings as opposed to the malar mounds. There are people that actually just naturally have malar mounds. A lot of times if you ask them, are there changes in it? If they eat salty foods, it may get worse. So know the difference if you don't in a malar mound and a festoon. But patients that have malar edema, if they have edema in their hands and you're going to be injecting their hands, you're going to cause a lot more edema. Many times if the hands are injected because they're dependent, they're not going to get swelling until up to 3 weeks after they've been injected. So let the patient know that you expect a little bit of swelling, but if they notice that delayed swelling, first of all, for them not to panic, but to let you know. And there's ways to manage it. Have them elevate their hands, but you need to make sure that they don't have any rings on or anything that's going to obscure their circulation. Patients and metabolism has a lot to do with when you're doing fillers. If you see somebody who is super thin and they exercise a lot, I always kind of chuckle in my head when I talk to them because they're asking me, how long is it going to last? And I tell them, on you, not as long as they did on most patients in the clinical trials. And I will tell them that their metabolism isn't smart enough to realize that they spent hundreds of dollars on this filler, that they're lucky, they're thin and they don't, they can get rid of weight easily, but they're unlucky when it comes to fillers because they're going to metabolize it faster. patient's dermal health, the location of an injection. In a hyperkinetic area, you're probably going to need to put a neuromodulator around the lips just to help from the metabolizing of the fillers in the mouth area, since that seems to be an area where it metabolizes fast. You also need to make sure that you choose the appropriate filler based on the anatomical plane where you're going to inject. And again, that's why we got into the G prime, knowing the characteristics of a filler and understanding all the fillers before you even start injecting. Probably the most common novice injector mistake is bumps and ridges. And it's usually because either, number one, too much was injected or the wrong filler was chosen based on the area that you were treating, not knowing that you might have needed something with not as high a G prime. And then the injection technique, cannulas, sharps, the depth, and also the pattern of injection. Was it retrograde? Did you put a bolus? Those are some of the things that come in to do with the outcomes. So some contraindications are active infection at the site of injection. I know that sounds silly to have to say it, but patients will come in and they don't understand that. So that's something more not for you to know, but for you to educate your patients on. How long has it been since they've had a fever blister or herpes breakout on their lip? They, many times will come in, well, it's on this side. You're not going over here, you're just doing my lips. That virus isn't smart enough to just stay there, it can spread. It has to be 4 weeks from the last time they had herpetic breakout before you should inject in that area. Pregnancy and lactating. Nobody is going to do clinical trials on a pregnant person or somebody lactating, so there is no clinical evidence. You can tell if it's a tetragenic medication. There's class A, class B, but who's going to take the risk? Not only that, I think I mentioned the other day, I had a patient that worked for one of the manufacturing companies and wanted their neuromodulator injections. And she was still nursing. And I just couldn't, in good conscience, inject her, knowing that there's a possibility of a spread. And I don't know for sure if it doesn't pass through breast milk. There have been a lot of people that say it doesn't, but I'm not going to be the one to take the chance. And an infant drink the milk, and they've got a much smaller body, and a dose that wouldn't bother us could potentially cause them a spread and their lungs to fail. So, a lot of people are kind of cavalier about it, but it's an aesthetic procedure. Don't take the risk. There are no studies, there's no proof, but I don't want to take the chance. Lasers and therapies with peels, you need to know what the chromophore is when you're doing it. Chromophore is water. Then you need to be conscious, because an older person, like I said, they don't have as much hyaluronic acid, so they don't have as much water in their skin. So they're going to have much more fragile skin when you run a laser. And also, if they've had a peel and they're going to have a laser, or they're going to have microneedling, you need to know when they had any of those treatments done, because they need to reepithelialize. So patients that have a history of an anaphylactic reaction, scarring, or sensitivity to any of the products, the ingredients in the products, that's the thing that I think a lot of people miss out on is, are you allergic to this? Well, the patient doesn't know, because they may never have ever had it. So you need to look at the ingredients that are in it, such as the Belafil with the bovine collagen. Are they allergic to beef? So know what the ingredients are in your product, and that way it'll help you with keeping somebody from having an allergic reaction. So again, the consultation should involve a good faith exam. It's an aesthetic procedure, but it's a medical procedure. And I'm happy to say that lots of states now have actually made that very clear to people. It's always been clear. If you do a medical procedure, you should do a good faith exam. But I think the evolution of med spas, a lot of people miss that and were cavalier in not doing it. And I know I've had several patients come to me that have come from other practices, and they're like, nobody ever asked me all those questions, because our questionnaire is very involved. I want to know, when was the last time you went to the dentist? When did you have the last vaccine? You know, have you had a sinus infection? All those kind of questions. You don't have to take their blood pressure. You don't, but it may get to that point. But right now, you need a good medical health, so you need to do a good faith exam. Again, we talked about the informed consent and the photos, but also cleansing and prepping the treatment areas. One thing that I've switched to is hypochlorous acid. There's been a lot of studies and a lot of arguments about using other topicals to cleanse and prep the skin that we may have used in the past. And because of the prevalence of biofilms, there was actually a paper written that said that all the other types of cleansers that were used were no better than just plain alcohol except hypochlorous acid. The nice thing with hypochlorous acid, number one, it's not flammable, so you don't have to worry about it with lasers, especially if you're doing tattoos or any kind of ablative laser. But if you get it in the eyes or in the mouth and the mucosa, it automatically turns to water, so it's not going to harm them if it gets anywhere in any of those orifices. Plus, it doesn't smell, it doesn't take their breath away. The depth of the rhytid determines the filler of choice and the product amount. Again, that goes back to knowing your characteristics and the rheology of the products. Linear threading for lips is what you need to know, and I know that there's a lot of different techniques out there, but this is the one that the test is going to question you on. And then for the marionette lines is actually fanning and in the nasolabial fold. And again, like I was mentioning, there's more than one way to get from A to B. So you may not use these techniques, and what you do in your practice and is working for you and is safe and efficacious is fine. But for test purposes, you need to make sure that you know these two. Post-injection guidelines. You can tell your patients to expect bruising to last for 3 to 14 days. It's not unusual for that. Just a tidbit in here, and it's not, I don't think it's in the book, but I always get asked by new injectors about icing and putting cold compresses on. Remember, when you ice, that they can get frostbite, and it can actually work the opposite and work like heat after 20 minutes. And also there was a study that there were a lot of cases of biofilm infections after ice, so because of the water supply that was used. I don't use ice anymore. I tell my patients, I don't want you to get overheated, and I want you to keep your heart rate down, because I've found that when people use ice, especially during a treatment, they'll put it on and then they'll wait and they'll talk or whatever. And what happens when the skin starts warming up is you get a rebound. So it's actually counterproductive to what you were trying to do with the ice to begin with. So the biggest thing is just make sure that the patient doesn't get overheated and that they don't do anything to raise their heart rate when they leave. And if a cold compress is comfortable, I usually just tell them get a baggie and put a paper towel around it and put that on their face. Not a washcloth, because it harbors bacteria. That way when they're done with the paper towel, they can throw it in the trash. Not to rub the area for 24 hours, except for Sculptra. We'll get into that. They need to massage 5, 5, and 5 with Sculptra after they have those injections to avoid any nodule development. If they have any pain, they should take Tylenol, not any aspirin or ibuprofen, to avoid from actually added bruising or start any bleeding. And then wait 1 week for any skincare procedures and 2 to 4 weeks for lasers. And that, talking about 2 to 4 weeks for lasers, is I'm saying in general, and that's for testing purposes. But when we get into the laser discussions, if you're doing hyaluronic acids around the eyes and you pull out an erbium, you're just going to burn it away, because water is the chromophore. So again, for test purposes, the 2 to 4 weeks for lasers is just from the book. So what are adverse events that can happen from fillers and volume enhancers? The blue hue that you see is a tyndall, And it's from superficial product placement in the dermis, and it's the light scattering. So if you had a prism and you put a prism down and the light came out, you would see the rays, and that's the same thing that you see with the Tyndall effect. It's just the light refracting off of the skin and the hyaluronic acid underneath it. So what's the treatment? Believe it or not, extrusion is easy to do, and it's a whole lot cheaper. So if you can put an 18 gauge needle in it and squeeze it out, then that'll work. I see that a lot of times when I have people come into me that have been injected from other practices and they have a lump in their lip. And rather than open a bottle of Hylenex and inject it in that area, I'll just get an 18 gauge needle and squeeze some out. And that way I'm not dissolving. Because if you start going in and try to put some Hylenex in an area, hopefully you don't dissolve too much because you want to get rid of their whole treatment. But just sticking a needle is a whole lot easier to just extrude some. But if you do use hyaluronidase, it says 20 to 200 units. The general rule of thumb, and I don't think this is in your book, but it's usually 10 to 20 units per tenth of a cc. But some of the other HAs that are more cross-linked do take a little bit more. So if it's more cross-linked, then it is going to take a little bit more. Again, the Vittrace is going to require a skin test, and it's just like doing a PPD. PPD, it's a patch test on your forearm, and you need to wait 15 minutes. Obviously, if there's a vascular occlusion, you don't need to do the skin test, but if it's for aesthetic changes, then make sure you give them a test and you wait. And Hylenex is probably the one that I don't even know anybody that uses Vittrace in the US anymore. Hylenex is so easy. It's already mixed. It's in the bottle. You pull it out. You don't have to do a patch test because it's synthetic. Again, here's a picture of lumps in the lip, and it's from superficial placement of the product. And the treatment is massage and extrusion or hyaluronidase. And again, first thing that you see is massage it first if you can smooth it out. So you need to know that. You don't just run and go get the hyaluronidase. Some might, but in the test, that's going to be the answer. Allergic hypersensitivity or infectious nodules. This is a lot of times allergic reaction to the BDDE, or if they have a history of multiple allergies, or to gram-positive bacteria. And it doesn't usually occur until the second week. You don't see it right away. And sometimes with the nodules from fillers, if they get a granuloma, it can take years before you actually see those. And the treatment might include injections of steroids or systemic steroids, hyaluronidase, and antibiotics. There's a whole algorithm to treating these, and I have seen a lot of these lately in the last couple of years. And when one of the brands came out, there was a lot of hypersensitivity nodules that came up. And there's a very big difference on how you treat them, because if you treat a infectious nodule, which is usually a biofilm, with a steroid first, you're actually going to potentiate the infection, and the antibiotics are not going to be as potent, so you're going to have to put them on dual antibiotic therapy and then use the steroids. And for me, when I get adverse events called in, the smoking gun that points at a biofilm infection as opposed to a hypersensitivity one is pain. There's pain with a biofilm infection, and it's usually unilateral. Sometimes they will become on all the nodules, but it usually starts out in one area where it was painful. So if your patient has a nodule and it's tender to touch, chances are you need to get them on antibiotics before you start the steroids. A herpetic breakout is caused by the herpes simplex virus, and again, it needs to be cleared for 4 weeks before you do any treatments. and you start them on an antiviral prior to treatment. But how can you do that when they're coming in and they're getting their lips done? So you need to know if they're going to be having laser treatments or anything over their perioral area. In your consultation, you need to make sure you get that information and you prescribe their antiviral so they can take them beforehand. For me, I keep it in my office because I have a dispensing license. And so if somebody has a history of HSV, I actually give them the Valtrex before I inject them. They sign a consent that they agree to take it. That's actually part of my lip consent. And then that way, when I give them their prescription, they don't have to rush to the pharmacy, because I know a lot of them are like, oh, I forgot to get it yesterday. I want to get it on board and I want to document that. And you need to know for the test, you need to know which one, and you need to know when to give it, and you need to know how long. Yeah.
I guess it's probably not corn related, but we've been told that about 90% of the population has it. Are you pre-treating everyone, or?
Only if they've ever had one. If they have a history.
Repeat the question.
Only if they have a history, I will. Granulomas are basically diagnosed by pathology, and again, they can show up 6 months later and up to several years later. And the only way that this is going to be labeled as a granuloma is if you have pathology or they have the mast cells in the area. And the treatment for that, again, is the intralesional oral steroids, hyaluronidase, subcision, and then 5-FU, and rarely excision, because if you cut it out, you're going to be taking soft tissue too. You're going to leave it. Once the offending product is gone, the granulomas do go away. So vascular occlusion and ischemia is usually it requires immediate attention, and you do feel sudden pain and immediate blanching, but the blanching isn't always going to be there. That can come later, but the biggest thing is I've seen it in the lips where they get the livido, kind of like that picture down in the corner where they have the discoloration down here. Sometimes it'll look like a bruise, and you'll have the livido, and you can see these patients at different steps of it here. You'll have the venous gradual darkening and dusky, but that also happens with arterial to a certain degree. So what do? You immediately stop injecting. You put warm compresses on, you massage, you inject hyaluronidase. There's a whole algorithm of the hundreds of units that you need to inject in the area. You need to give the patient aspirin and have them chew it up. Topical nitropase is debatable, but that's what's going to be in the test. The theory behind doing the nitrile paste, not doing it, is if there is an occlusion and you put nitrile paste in it, you could possibly spread it and make the occlusion go further. If it's not in the retinal area, it could spread to it. So that's a debate. Medrol dose pack, antibiotics, and then contact a plastic or an oculoplastic stat. You should have your plan of action before you start injecting. So if you're new injectors, you need to have your emergency kit all set up with all of those different products in them, and you also need to know who are you going to call if you have an emergency. And it is not the manufacturer of the company. Don't call the company, because they're not going to be able to tell you what to do. They're not allowed to practice corporate medicine.
Sorry, I had a question. On your slide it says 325 Raspberry, but I think in the book it's at 81. Does the dosage matter on the test?
It's going to be this on the test.
The 325?
So for radius and Sculptra nodules are microparticulate aggregates of PLLA or calcium hydroxyl apatite, and it's a lot of times got a lot of inflammation on it. It's more hyperproduction of fibrotic tissue, and it may actually be the product too. You never know. So, but there is a treatment to do for it, and you can inject with sterile water. This says sterile water and massage. In real life, I would put a little lidocaine in that just to be nice, because a patient is not going to like it when you're massaging. And granulomas, again, must have pathology to confirm the diagnosis. And that treatment, again, is intralesional steroids, 5-FU, saline plus lidocaine injections, mechanical disruption, and again, the last resort is excision. Bellafill, there's rare HAs, but they do have a possibility of hypertrophic scarring, granulomas, allergic reactions, and telangiectasia and erythema. They have the same adverse event profile as any filler. They don't have any unique adverse events that don't happen with any other fillers. The only difference is it's a long-term product. So if you have a long-term product and you have a problem, it's usually a long-term problem. FDA-approved botulinum toxin type A. We have 4 of them in the U.S. right now, and we actually have another one that'll be coming soon. They had our party the other night. Know the generic names is onabotulinum toxin, abobotulinum toxin, and incobotulinum toxin. The manufacturers are there, but you want to know the generics. Jeuveau came out in the summer, and then we also have another one, Daxi, coming out probably in 2020. The black box warning is what I referred to. You need to know this. It's mandated on all botulinum toxins, and it discusses the distant spread of the product. And there were several deaths in children that were given clinical dosages. But because these are, the only one that's cosmetic medication is Jeuveau. All 3 are considered medical and cosmetic, so they have to put the black box warning on them all. For cosmetic reasons, you're not going to get the hundreds of units, but they still have to put it on here because it happened with other children. The mechanism of action is that it inhibits the release of acetylcholine at the neuromuscular junction by binding to the receptor site of a motor nerve terminal in striated muscle and blocking the neuromuscular transmission. Without acetylcholine release, the muscle can't move. With the new SNAP25 proteins, when they're resynthesized after approximately 3 months, then you're going to have the effects of the Botox dissipate and they'll have return to movement. They are product, dose, and patient provider dependent. Onabotulinum toxin is Botox, and it's reconstituted with preservative-free saline, 2.5 cc's, and you have to use it within 24 hours. Remember that you may mix it with not preservative-free, but for test purposes, you need to put preservative-free. Abo, which is Dysport, is 300 units, and it's freeze-dried and has trace amounts of milk protein. So again, if they have an allergic reaction to protein and milk, you need to not use this on them. You add 2.5 or 1.5 cc's per 300 vial, and it has to be used within 4 hours. The others say 24 hours. This is the only one that says 4 hours. And it is not recommended in children or pregnant women. Inco, which is Xeomin, is reconstituted with appropriate amount of preserved saline. It says preserved, it's non-preserved. I don't know why it says preserved up there. They all have non-preserved saline in them. And you can store these at room temperature. You don't have to refrigerate it until after it's been mixed. And they come in 500 unit and 100 unit. This is the only one that is 150 kilodaltons that does not have any accessory proteins. Make sure that the solution is clear and not cloudy. And you also need to have the vacuum when you put the needle in to reconstitute it. If it does not pull the saline in, put the vial away and call the company and turn it in. The consensus report is that preserved saline is less painful, and it's the bacteriostatic saline because it has alcohol in it for the preservative. Even though the reconstitution volume varies, results are dose dependent, and it's mild agitation is okay. Most of them say no agitation, but mild is okay. And neurotoxin can be stored in the refrigerator for up to 6 weeks without a decrease in efficacy. Here's the different muscles, the frontalis, and it originates from the hairline up to the procerus. understand that muscles actually, if they're vertical, the lines are going to be horizontal. So the horizontal lines in the forehead are from the frontalis, and overdosing those with a neurotoxin can cause brow ptosis. It's not just overdosing, it's misplacement too. The corrugator supercilii are depressors, and they lay beneath the frontalis and above the orbicularis oculi, and they draw in and down the brows, and they produce the vertical creases between the brow. The procerus communicates with the depressor supercilii and the OO, and it draws the medial brow down, creating a horizontal crease. The orbicularis oculi is a sphincteric muscle, and the contraction at the lateral margin is what causes the crow's feet. The levator is actually on the upper lid, and it's primarily the elevator of the upper eyelid, and the Mueller's muscle is within there. So if you have a patient that has a dropped lid from dispersion of the neuromodulator into the lid, you can actually inject them with an alpha-aldrinic drug. And what the iopidine does is it relaxes it and lets the Mueller's muscle slightly lift the eye open. Nasalis is on the nose, and it is the superior nasal dorsum, and it basically is what causes the bunny lines or wolf lines in men. I don't think I've ever referred to him as a man to wolf lines. I just call them all bunny lines. The levator labii superioris alloqui, nasi. We all call it the LSAN, but that's the official name for it. And this contributes to the bunny or wolf lines, and this can actually create a gummy smile via hypercontraction. So if you've got somebody and you have a test and they are going to ask you how many units on this and where do you inject the LSAN if they have a gummy smile. Levator labii superioris, contraction of the upper lip. And it's rarely injected, but a lot of times if you've got somebody that's got an uneven smile with Bell's palsy, they are thrilled to get this done. Just be really careful that it doesn't spread down to the rhizoris, because then they're going to drop then they're not going to be able to move the rest of their mouth. And in addition to making general facial expressions, it's primarily responsible for elevating the upper lip. And so if you inject it too deep, too inferior, it'll result in the ability to lift the lip when smiling, was what I was saying, if you have it spread. The zygomaticus major and minor. The zygomaticus major pulls the corner of the mouth up and lateral in a smile, and the zygomaticus minor draws the middle portion of the nasolabial fold along the middle portion of one side of the upper lip, outward as well as slightly upward. I rarely will inject the zygomaticus minor, but I have in younger people who actually have an awkward smile. They get they're fine when they're reposed, there's no wrinkles, but when they smile, it tends to make like a really deep cleft in there. And so by injecting that, it actually will help it. And it's funny because most people won't inject that area, but it's an easy injection as long as you feel the muscle and you pinch it up to keep it from spreading. Orbicularis oris is another sphincter muscle, and it's around the mouth, and it seals the mouth, purses the lips, and causes the radiating lip lines. Depressor anguli oris, which we all know is the DAO, is in the lower face, and it turns the corner of the mouth down and creates a frown. know that one. And also probably would be a good idea to know the dosage too. Depressor lay-by. The complication of treating the DAO is the migration of toxin into this muscle, and it creates an asymmetric smile. So you can see the patient is trying to smile and the mouth just doesn't move. And it makes them look like they're a stroke patient. So you need to know those 2 points. Depressor septi pulls the nasal tip down. So if you've got somebody in a few patients where when they walk in it looks like, and I don't mean the term, but a porcine nose, let's say a piggy, but they have very prominent nostrils. By injecting that, it can actually bring their tip down a little bit, and they get so excited because they didn't know that there was actually something that they could do really easily besides having surgery, and they don't want to have surgery for that. The platysma creates vertical bands and also creates the horizontal necklines. Mentalis with a chin dimpling is called the Poder orange, and sometimes you'll even hear it called a pebble chin, but for test purposes, no, the Poder orange is the chin dimpling. And you can also get a horizontal crease below the lower lip, and you might be asked the dosage in that area. So know how much you have to inject for chin dimpling and Poder orange. The masseter is a chewing muscle, and it raises the mandible, but hypertrophy of this muscle can cause a square jaw, and this shows you the areas where you can indicate that you're going to inject. And again, you don't want to inject too medial because you'll end up getting the rhizoris, and you go deep on this. This is one of the ones where you can't use your little BD syringe. I would definitely recommend using just a regular 1 cc tuberculin and getting a 30 gauge 1-inch needle, because you do need to go really deep on this. On-label use, the glabellar frown lines, all 3 FDA approved for that area, Ono, Inco, and Abo. The only one that is approved for lateral canthal lines and forehead lines is Ono, which is Botox. And then also Botox has therapeutic uses, and some of the others have them for spasticity, but for hyperhidrosis, Allergan actually has a patent on this, and the other companies can't even give you any discussions on using it for hyperhidrosis. Off-label, everywhere. I mean, everywhere you can think of, I call it the aspirin of this century. Everybody uses it everywhere. But as a licensed provider, you can legally prescribe and use an FDA drug in any way that you feel can benefit the patient and that there is scientific evidence on it. That is why they allow the companies to do investigator-initiated studies. If you've ever heard of an IIT, is so that there's documentation of off-label use and scientific guidelines on how to do it safely. So contraindications is obviously hypersensitivity to any botulinum toxin preparation or to any of the components in the formulation, and infection at the site of injection. What are some warnings and precautions? So if they've got peripheral motor neuropathy disease, they've got ALS, they've got myasthenia gravis or Lambert-Eaton syndrome, then you shouldn't be using this on them. So basically, people that have neuromuscular issues, you wouldn't want to use a neuromodulator on them. Neuromuscular diseases may be at increased risk of clinical significant effects, including severe dysphagia and respiratory compromise. And with drug interactions, we talked about the aminoglycosides, but also calcium channel blockers and muscle relaxants. So you need to watch these patients closely and let them know that if they do get a neuromodulator, that they could be potentiated. I personally wouldn't inject anybody that's on an aminoglycoside. Every now and then, the calcium channel blockers or the muscle relaxants, they'll have it PRN as far as the muscle relaxants, and they won't tell you. So again, that's in my consent form. So it may be something you want to add to yours. Using anticholinergic drugs administered and with Botox, again, may potentiate the systemic effect of them, and that can lead to blurred vision. And with pregnancy and lactating, we already talked about that. Patient consultation. The line forms perpendicular to muscle fibers, and identify their asymmetries. And sometimes I've found that just by looking at the patient, when I take their before pictures and I look at them, I notice even more things in the photo. So when you take your before and after pictures, look at them. You may see things in that you didn't notice on the patient looking straight on at them. Also, their facial shaping and balance versus an isolated wrinkle removal, because remember, the neuromodulators are yin and yang. There's an opposing. So you need to keep in mind, if you knock out one muscle, what is it going to do and affect on the other? That's huge, especially with the eyebrows and the forehead. And the biggest one that, and I kind of chuckle because I have people come into me that have been to someone else. They're like, every time I go, I get the Spock eyebrows. And again, when you do the glabellar injections and you don't do anything on the forehead at all, that is going to increase your chances of getting the Spock look. So a lot of times, just going in when you're doing the glabella and if they already have arched eyebrows anyway, I usually just put one unit up in their frontalis so that they don't get it. Dosages. So remember that thicker skin takes a higher dosage, and a larger muscle means a higher dosage. And people with skin of color and males have thicker skin, so they generally are going to need a higher dose than what your average amount that you're thinking might be. And again, these tables that are in the core curriculum, the 4th version, on page, well, they're in chapter 29, and it's table 29.1 and 29.2. They go into the dosages that I was talking about that you need to be aware of. So post-treatment instructions. Have them exercise their face. That actually does move the liquid around and helps resorb the medication when it's been injected, so hopefully there's not dispersion. But make sure they understand not to massage the area, because again, they can move it, but they also need to make sure that they don't have on a tight headband or a hat. A lot of the girls will come in with their hairbands really close to their forehead, so I tell them they can't put it back on after I've injected them. I just have them keep it off, because a lot of them have that crazy habit of taking it off and on, and I don't want them moving it around. Also, keep their head elevated above their heart for a few hours post-injection. For test purposes, you need to know this, but there's a lot of debate about whether that's realistic or not. My biggest thing is, I don't think it's moving anywhere when they lay their head down unless they put their head on the pillow. But the big thing is just make sure that they're not touching it or they're not doing anything that can compress it. And then it's a good idea to bring them back in 2 weeks to just reassess them. I think the easiest way to lose a neuromodulator patient is to not have them back in 2 weeks, because if they need 1 or 2 units, especially that Mesfito or Spock, it's an easy, quick fix, but you'll lose someone if you don't do that. So what do you need to know? So in your mind, see if you can answer these questions. Know what treatment area and the targeted muscle, for example. A dimpled chin requires treatment of what muscle? The nasal tip droop treatment is 2 units into what muscle? And then a gummy smile is 2.5 to 10 units into which muscles. That should have a clue there. And here's the answers in case you weren't sure. And then that's a copy of the tables that are in the review. So what are the complications? These are found in the table 29.3 in your core. The frontalis overdosage is brow ptosis, and again, like I said, it's also misplacement of the neuromodulators. The glabellar migration into the levator superioris is the eyelid ptosis, and orbicularis oculi migration into lateral rectus muscle is diplopia, or migration into the zygomaticus major is smile asymmetry. Orbicularis oculi weakness, dry eyes, ectropin, malar edema, and scleral show. That's usually on the lower lids, and the malar edema can happen by loss of the pumping action of the lymphatics in there. The dry eye and the ectropin is because they can't close the eye. So if you don't do a snap test on your patients, which is just pinching that lower lid skin and watching how slowly it retracts back, I would not do neuromodulators in the lower lid unless you do that snap test, because you'll end up with a dry eyes ectropia and a scleral show if somebody is too lax and needs a blepharoplasty. Nasalis migration in the LSAN can give you an asymmetric smile. Depressor septi migration into the levator labii. They can't lift their upper lip. And DAO migration into the depressor labii will give you an asymmetric smile and inability to lower your bottom lip. Okay, Kybella, there was a question the other day if this was going to be on the test. It's not in the core, but I've heard that it might be on the test. So I want to go over Kybella with you, especially if you aren't accustomed to using it. It was FDA approved in 2015, and the indication is for contours and improves the appearance of submental fullness in adults. For improvement in the appearance of moderate to severe convexity or fullness associated with submental fat in adults. Same thing. So here's where the Glogau scores come in. Up at the top where you see the 0 through 4, this was the clinical trials, and this was how they decided in the phase 3 studies what the results were and if the product was basically effective. And so that's where I was mentioning the Glogau scores, that you all probably don't ever use them when you assess your patients, but this is a time when you may see them. So the ideal profile for someone who is a candidate for Kybella is distinct mandibular borders, subhyoid depression, visible thyroid cartilage bulge, visible anterior sternocleidomastoid muscle, and cervicomental angle. The ideal proportions are 90 degrees, and the other information is just FYI. You don't have to know that for the test. But know that it comes in 2 cc vials, and it's 10 milligrams for a vial, and they're supposed to be single patient use. And I can tell you, you'll use 2 cc's on one patient when you do it, because usually it takes a couple of vials per treatment. You can store them at room temperature, and you do not dilute it. I mentioned the other day that I've heard that people add lidocaine to it. That is not on the test, so if you do that, don't do it, or don't put it on the test. The technique is injected directly into the fat cells, so you have them just lean down, and you need to pinch it. If you can't pinch it, make sure that you don't have the platysmal muscle in there, and a way to do that, again, like I said, is just have them bend down, and literally you'll feel the protrusion, you'll see it, and then you can hang on to it, pull it up and away from that muscle. And once you inject those areas, you are going to consider cytolytic, which is meaning that you're killing them. They're not going to shrink. They're actually going to die, and you're going to metabolize them out. Make sure that this is not injected into the skin, because it kills skin too, not just the fat. So what are common reactions? And this is very common, and this is something that you need to advise the patient that they are going to have occur when they have the treatment done, is edema, swelling, bruising, hematoma, pain, numbness, erythema, and induration. Hematoma maybe not, but all the rest, I would definitely tell them that is a huge possibility they're going to have. And it lasts for a while. It's not going to go away in a couple of days. It can last for, I hate to say it, but I've had some that have had it last for a couple of weeks, which the Allergan reps will tell you, no, that's great. That means they had a great inflammatory reaction, so they're going to have a great outcome. So it does take a lot of hand-holding to convince the patient and have them go through it. But I have to say, the ones that had really, really bad swelling, they did have a great outcome. What are some adverse reactions? Paresthesia, nodules, pruritus, which is itching, skin tightness, site warmth, headache, pain, hypertension, nausea, dysphagia, injection site hemorrhage, discoloration, and lymphadenopathy. These all occurred in 20% of the patients during the test, but those symptoms were gone and resolved. Only not even 1% had them by the end of the study. Safety information. So if you do not know where the marginal mandibular nerve is, you must know where that is to do this procedure. Otherwise, you're going to have a nightmare on your hands, and that is not, it's not a common problem, but I have heard of issues of that more than I would hate to admit that other people have it. So know that anatomy in that area, because it's not an area that we've been injecting for a long time. It's fairly new to most people, unless you've been in the operating room and you're really familiar with it. To actually inject in that area, it might be a little foreign to you. The proper injection technique is imperative. And dysphagia, if they have any issues, do not treat them, because with the swelling and the irritation, it's going to potentiate it. If they have any bleeding abnormalities, I usually have them get their primary care or their prescribing physician for that medication to give them clearance. And I'll just direct them to the product website, because it has the PI on it, and their providing physician or provider has to give them an okay to do it. And then obviously if there's tissue damage in the area, don't inject in that area, and make sure that you know where the glands and the lymph nodes and all the muscles in that area are. I can't tell you enough. I mean, we heard that today. I talk to so many people who are unaware of the glands and the just the anatomy in the neck area, that it is a new area for so many people. Study it before you even do this, and don't count on the Kybella rep to teach you that. You really need to learn that on your own. One of the things that they came up with was the Easy Kybella. It's kind of help give out instructions. So the first thing you want to do in the Easy is the E, is evaluate the patient. Check them out to make sure that they don't have any of the special considerations like thyromegaly or cervical lymphadenopathy or submandibular glands are pronounced. Because if they have any issues with a submandibular gland, it's in close proximity to where you're treating, and you need to be aware if they have any problems there and you nick that, you're going to have a nightmare on your hand. If they have prominent platysmal bands, do your neuromodulator before you do the treatment. You can do that 2 weeks beforehand. Makes doing the treatment so much easier. Skin's a lot more taut, and it's so much easier to do. And then just make sure that they haven't had any treatments in that area, and if they had, know what they've had done. If they've had liposuction in that area, or they've had platysmal plication, they're going to have scar tissue in that area. And when you're using those little tiny needles, if you've got a lot of scar tissue in that area and you inject and you don't get the needle all the way in, you're going to be dripping the product and they're going to have uneven treatment results. So make sure that you know their surgical history in that area when you're going to be doing the procedure. Application, clean the lower face and anterior neck. Again, hypochlorous acid or alcohol. And male patients need to be clean shaven. The grid's not going to adhere to them. Use a marking pencil to treat the area. And if you have a Sharpie, it's much better to use in that area because the pencils start wiping off when you start prepping the skin. And then apply the skin. The skin grid comes in the box, and it needs to go on clean, dry skin, or it's not going to stick. Once you put that grid on, it's kind of like the little tattoos you used to get when you were little where you need to wet it. It actually will put the dots on there and then peel that paper back slowly. If all of the dots don't come off, get a Sharpie and just put dots where those little dots transfer didn't come through. You do not want to miss the dots in the area because otherwise, again, you're going to have an uneven treatment. And then when you're done, get a woven piece of woven 4x4 as opposed to the soft. Saturate it with some alcohol and just scrub that Sharpie off of there or those dots. If you don't clean them up, the patient's going to try and do it at home. I don't want them touching it. I don't want them messing with it, so I make sure they're all cleaned up before they leave. And then you're going to select the dosage. And an easy way to know is if you have 20 dots, you divide it by 5, and that's going to be 4 1 cc syringes. And you can take the number of syringes and divide it by 2. So that's how you'll know how many vials you're going to need. So on that patient that had the 20 dots, they needed 2 vials. No more than 10 cc's or 5 vials in per session. I don't think I've ever injected that many. On label. Maybe off label people might, but mine won't want to pay that much. They're expensive. Post-treatment injection. So apply ice, ice, ice. Ice the area. Patients will love you. They will happily take the ice and hang on to it. Do it for at least 5 minutes, but I usually keep it on them about 15 minutes. And even at that, they want to hang on to it. And again, remove the marks. Before they leave your office, have them animate, smile, and assess their swallowing because you want to make sure that you haven't hit any of the nerves and you don't have any issues with dysphagia. Make sure they understand, like I said, the swelling and the discomfort, that they're totally aware that that's going to happen or you're going to get a lot of calls that night. And we're ready for a break. Okay, we're going to get started on the fun part. I heard a chuckle. So we're going to go over laser, light, and energy devices. And laser actually is an acronym for light amplification by stimulated emission of reaction. So the characteristics of laser light represents a small portion of the electromagnetic spectrum. So you're going to see the different colors. And if any of you have any, especially the IPLs, you'll see the different colors for the different handpieces, and it's based on the wavelength for that handpiece. So laser light is attributed to wavelength, the frequency, the velocity, and the amplitude. So you're going to hear me use those words a lot. Those words are how we discuss the settings and what we're actually going to be doing and how do we know how to treat. So properties of regular light and with laser light, you can see in the diagram that a laser light is monochromatic and regular light just has all the colors of the rainbow in it, literally. And a laser is directional, is coherent. That means their photons travel together and they're columnated. The photons travel parallel with very minimal scatter. It's literally just like this, where you can see the beam. There's not any light going all over the place. It's literally in one little spot. If I had a flashlight, the light's going to be a lot broader. So components of lasers. Number one is the laser medium, and that excites the laser action and the photon movement. And there's actually different mediums. It's gas, which is an example is a CO2. Liquid is a pulse dye, and a solid is an alexandrite. If you've heard of diode lasers, and we're going to discuss those, they don't have a medium. The power supply can be just as simple as the plug that it goes into. They add energy to the medium, which is the machine, and they can be electric current, a white light, or radio frequency. Number three is the optical cavity, and it surrounds the medium and consists of reflectors, or like a chamber of mirrors, and they support the feedback system for amplification of a light. Remember, that's part of the acronym of laser. And then number four is the delivery system, and it allows the light to be emitted to create the beam. So it sounds really technical, and it's like all these different things, but if you stop to understand it, it shows you in the diagram over there the actual pieces, and it's got the mirror and then how it comes through. So it sounds more complex than it is. So properties of light on the tissue. Light hits the skin and converts it to heat, and it causes a change. It's that simple. And the absorption creates the reaction. If there's not absorption, there's not a reaction. It's that easy. You need to know that. So the mechanism of action, and this is kind of the algorithm. The light from the laser source, it hits the tissue, and the cell absorbs the energy, and then it creates heat within the cell. It lowers the moisture, and then it destroys the cell. And the tissue or the target is based on what the chromophore is. So that's the new word that's probably, if you haven't done lasers, to understand as a chromophore, and that's just the same thing as a target. So melanin and pigment in the skin can be a chromophore, the water content of the cells, and hemoglobin. And we'll get into the different wavelengths and how the wavelength is picked up by those chromophores. So wavelength, physical distance between the crest of successive waves, is what a wavelength is. They're selected based on how well the target is absorbed by the chromophore. And it means what's it going to take to literally just make the cell lose the moisture and the cell to die, or in other words, just to cook it. So it's chosen based on what you want to treat. So for hair, it's the pigment in the hair. You can't treat white hair because there is no chromophore. Wavelengths are measured in nanometers. So it refers to the physical difference between the crests of successive waves in a laser beam. Typical medical lasers are 1064, which you can see over here, they're near infrared. And then 2940 is the mid-infrared. Only laser wavelengths between 400 nanometers and 700 nanometers are visible, which we're going to get into the laser safety. So if you trigger the handpiece and you won't see the laser, it can still burn somebody's eyes. So anyone that comes in a treatment room has to have on glasses, including the patient, or some type of optical protection. But we'll get into the specifics on those when we get into the safety. So the power density is measured in watts. And 1 watt means 1 joule of energy, and that's in 1 second. So when you're setting the settings on your laser, fortunately most of them come preset, so you don't have to figure them out. But based on the outcome the patient has, you may raise or have to lower the settings. So that's why you need to understand the joules, and then we'll get into the fluence and the other things. So the pulse duration is in milliseconds, and you'll see MS on your machine, and that basically is just the amount of time the energy is going into the skin. So if you do more superficial, your pulse width is going to be shorter. And if you want to go deeper, the pulse width is longer. Fluence is the energy, and it refers to the amount of energy, which is the joules, delivered to a treatment area. And it's called the dose of energy or energy density. So fluence equals the energy around the area. And all it is the amount of heat that you're putting in. So if you have somebody who has really thin skin and you're doing skin rejuvenation type laser, and that means they don't have a lot of water in their skin, so they don't have a lot of a target. So that means you need to lower the fluence, otherwise you're going to burn them. Does that make more sense? See, it really is easy. Selective photothermolysis. A laser-induced injury or treatment should be confined to the microscopic sites of selective light absorption in the skin, whether it's the chromophore for blood vessels, pigment, or hair. And you need to make sure that it causes minimal damage to the surrounding tissues. So there's 3 requirements when you're doing the choice of what their settings can be. And again, we talked about what is the pulse width or duration, and that has to do with how much energy are you putting in. The wavelength, what is your chromophore? So what are you treating? Are you treating hair? Are you treating blood vessels? Are you treating pigment on the skin? Or are you treating maybe fine lines and rhytids? And then the energy influence is just high enough to inflict thermal injury to the target. You don't want it too high because you're going to blister the patient. If it's too low, you're not going to get any outcome. So stronger absorption by a target, you use lower the fluence. If they didn't get enough absorption, you need to raise the fluence. Laser effects in the tissue is when photons are absorbed and you get a clinical effect. So there's 3 types of laser effect categories. There's a thermal effect, and this one is the most significant. It gives the most surgical result type treatments, and that's what they use in the OR. And they use a CO2 or an erbium YAG, and it stimulates, it necroses, and then it coagulates. So instead of using a scalpel and then coagulating with any of your pieces that you're going to coagulate with, you can do it with a laser. There's a chemical effect, which is activated by light-sensitive meds to disrupt cell function, and it's called photodynamic therapy or PDT. The medications that are used to do that are Levulon and Alumera. Levulon is used to treat actinic keratoses. The FDA approval is for the scalp, but in essence what it does is you have to put it on the skin and it makes it become photosensitive, and it seeks out irregular cells, and then you use a light therapy to stimulate it. It's used a lot of times for cosmetic reasons, for either somebody who's got a lot of rosacea or pigment issues. And when I use it in my practice, I'm in Florida, so we have a lot of 8Ks. Sometimes it'll actually surround the AK, but they also get a cosmetic result with it. So it's kind of a twofer in my place, but it just potentiates whatever light source you're using, especially if you're using an IPL and they have a lot of pigment or rosacea. It kind of turbocharges the machine without having to increase the fluence and burn the skin. And then there's also a mechanical effect, which is acoustic sonic waves to break up kidney stones and lithotripsy. So how do you choose the right laser for a procedure? How do you know? Again, we talked about the chromophore, and it defines the wavelength choice. That's how you're going to know. It's kind of like the G prime on fillers. How deep in the skin are you going? Your chromophore is going to tell you what your wavelength is going to be, and also the patient's Fitzpatrick. And also, I would say their age. What's the condition of their skin? Because some of the lasers are too harsh on more mature skin, or you just have to turn them really way down. What correct pulse width duration does the target need? How much time does it take to cook it, basically, is what it's asking you. How much energy, how long do you have to let that energy penetrate into that cell to basically obliterate the tissue or the cell that you're trying to go after? And what is the correct pulse frequency? It's the number of pulses. How many times do you have to pull the trigger in that area? You may have heard of pulse stacking, and don't do it until you're like really experienced with lasers, because each time you hit it with a pulse, it's delivering heat, and you can get, that's where blistering happens very frequently. When you're more experienced, for instance, for me, one of the places that I actually do multiple pulses is when we start talking about the pulse dye and the vessels around the nose. When you hit a vessel, a lot of times it'll spasm, and if you can get it quick enough, you can get it while it's spasming, and then you can knock it out. But you have to be really careful because, again, like I said, you're delivering a lot of energy, which is heat, to that area, so you risk blistering them. But that's where basically the pulses comes in. I wanted you to know that term, so if anybody ever tells you to double stack them, that's what they're talking about. Don't do it till you know your machine intimately. What are your cooling settings? A lot of machines are automatic, especially the IPLs. They have cooled heads. You don't change the settings. They're just cool. And what's your starting energy? The best thing to do is do a test patch in an area of where you're actually treating. Don't do it in an area. If you're going to be doing their face, do it in a lateral area that's closest to what the rest of the area is going to be. If you're going to be doing their décolleté, you need to do it in a discrete area, in the décolleté area, and give yourself enough time. I usually wait about 15 minutes because, especially in areas where there's a lot of bone and there's not as much tissue, the heat doesn't basically dissipate as quickly as it does where there's a lot of fatty tissue. You can't cool it as easily. So be prepared with something to chill them, to cool it down. And if they're feeling pain, you're way too high. It should be uncomfortable but not painful. And I know that sounds crazy because I usually tell the patient, it's going to sound nuts, but once you get into it, it won't hurt anymore. So they got to get into the pain, but it shouldn't be to where they're miserable. They should know you're there but not be painful. A pulse dye laser is the first type of laser we're going to talk about, and it's usually used to treat vascular lesions because the chromophore is oxyhemoglobin, and the wavelength is 585 to 595, and it causes thermal destruction of vessels. And a lot of times there's profuse bruising afterwards, and again, that can happen, and the patients need to know that that might be a possibility, because when they get lasers, they don't have a clue what can be the possible outcome other than maybe they know that it might, be a little bit red. But if you're going after vessels, it's a huge possibility that you could have some bruising, and so they need to be aware of that.
Is this what they call the V beam?
Yeah. So your clinical endpoint is going to be bruising, vessel darkening, or vessel disappearance. Ideally, you would like vessel disappearance, but it's realistic that they need to know that they may have to have another treatment to get rid of it, which is why I'm saying that we do the pulse stacking, because if you stack, sometimes you get the bruising and then you can knock it out with the next zap. But you don't want to see graying of the treatment because you just burned them. A KTP is also vascular lesion, but it can also be used for pigmented lesions. And one of the things that, and we'll get into this with IPLs too, this wavelength goes in to destroy either the blood vessel or the darkening pigment area on the pigmented lesions. The laser's not smart enough if there's vessels and pigment in an area to say, oh, she only wants to get rid of the vessels. Let them know that if they've got pigment on their face in an area where you're going to be treating vessels, that those pigmented areas are going to get really dark. They'll actually fade, which is a win for them. But if they don't know that that's going to be dark and they have an event coming up, they're going to be unhappy if you don't warn them of that. So usually I tell them that it looks like your freckle got charred. But the good news is it's going to peel off in about a week to 10 days, maybe a little bit longer. But caution them that as the epithelium sheds, that pigment will shed, for them not to pick at it, because it literally looks like a scab underneath the skin. And it looks like you should be able to just pick it off, but they don't want to do that because then they'll end up with scarring. There is less bruising with this type of laser than with the pulse dye. So if you want to avoid the complication of bruising, then you're going to want to use a KTP, and you need to know that. And used on superficial red telangiectasia up to 1 millimeter, like the little nasal veins, and benign pigmented spots. So ablative laser resurfacing. This is actually vaporizes the affected tissue, and the laser beam goes through the top layer of the epidermis of the skin, and the mechanism of action is that it burns the epidermal layer down to the dermis. Non-ablative means that the laser beam coagulates an affected area, and it focuses specifically on tissue under the surface using very specific wavelengths, and it's used to kind of do remodeling. We're going to get into a few more details about the fractionated, but I wanted you to know about the ablative ones first. So the chromophore is water, and it's used to vaporize the tissue. Again, it's going to basically char off the epidermis, and it's usually a CO2, an erbium YAG, or YSGG. It's full field, and it goes deep tissues towards the surface from the cells into the hair follicles. You need to know this. This has a lot to do with the healing, so this is an important aspect on ablative lasers. Because if you do ablative treatments in areas where there's not hair, it's a lot slower to heal and a lot easier to burn them. So fractional ablative is a lot different than ablative under a microscope. But to the patient's eye, sometimes they look just as red, and they have a lot of tissue injury and swelling. But the point under the microscope you can see in these pictures up here is that there's what they call microthermal treatment zones. And it basically is that the tissue adjacent to where the laser beam went is not damaged. So as opposed to the complete ablative, this is a fractional, and what that does is it leaves healthy tissue in the area, and it helps with speed and resorption and rehealing. There's an example of two of the different ones. I don't think they're going to be on the test. Like I said, there's not going to be brand names, but just as an example, the Fraxel was renamed the Restore, and there's one that's a non-ablative fractional, and then there's one that's an ablative. And it just totally depends on the depth that you set, the wavelength. So ablative applications can treat skin lesions, superficial dyschromia, AKs, sebaceous hyperplasia, and photo damage. And these are awesome for treating those sebaceous hyperplasia. There's not a lot that totally gets rid of those. If you do a lot of the chemical treatments, they still come back. But this actually really just kind of ablates them. And it's because it's resurfacing the superficial skin, and when you do that, it gets the deeper rhytids too, and it improves the texture of the skin. It excises keloids, but again, if you get too much fluence in there, you can actually make them worse. And you can also vaporize warts, but remember the plume that comes from lasers. A wart is a virus. So wear a mask, because you can actually, you can breathe in the plume, and you should have a smoke evacuator next to that to draw that plume so that you don't get the virus on you, because you can actually get their warts. An ND-YAG is pretty much an all-purpose laser. It's a 1064 wavelength, and it's the deepest penetrating of all the known wavelengths. And it's able to penetrate all follicle depths. It has longer wavelengths, so these are ideal for darker skin because it's not hitting the epidermis. It's going deep down into the dermis. And it has a melanin, it has an affinity to basically be a laser for the chromophore for melanin. It has a lesser affinity for melanin, which is why it's great for darker skin. So you can use it on the Fitzpatrick 4 through 6, again, because it bypasses where the melanin cells are in the upper skin and will penetrate down deeper. Some of the applications that it's used for is for tattoo removal, vascular lesions, and also for surgery. A Q-switched laser, it actually emits really super short, high power pulses, and it is great for tattoo removal. It's higher than would be produced from some lasers in a continuous wave mode. So it's really, really fast, and it goes in deep. Again, like I said, it's known for tattoo removal, and it does this by an acoustic means. Remember, we talked about the different characteristics, and it breaks up the ink, the pigment that's in the epidermis and the dermis. It basically breaks it up, and your body metabolizes it through phagocytosis. A lot of times with the breakups on it, if they have white pigment, most lasers won't see white and it won't affect it. That's why if you do markings, you'll use a white pencil when you're using a laser. But with a Q-switched, it'll actually turn it black because it does go after all colors. And it can be used to treat café au lait, age spots, and various types of nevi. And here's just an example of tattoos. They're going to need at least 3 treatments. And you're going to want to space them out. They get wound they're going to have to go through wound healing, and so you need to let the epidermis heal and re-keratinize before you treat them. And again, on these patients, you need to do a patch test. They're going to get, like I said, there might be some wound healing there, there might not. The goal is not to have it, but you want to give the blood the chance for your system to go in there and phagocytose all that pigment in there before you come back in and do a treatment. Because if you do them too fast, you may be doing treatments unnecessarily and actually hitting charred ink. So give it a chance to work its way out before you come back in and treat it. And the 6 to 10 treatments is realistic. I don't know very many people, although the Q-switched are getting better and better, but even with 3, a lot of times you'll get what's down in this middle picture where you see the lightening. It won't totally go away. So a lot of people will be okay with that, and then they, believe it or not, they end up getting just a different tattoo over that. Maybe somebody's name that they didn't want on there or whatever, so they have it lightened and then they get a tattoo over it. Hair reduction. You can use an alexandrite, a diode, an ND-YAG, 1064, and even an IPL. And it says IPL is the least amount of downtime, but the reason that too is it might not give you as great a result. The IPLs, I think, to me, the one that I have, and I have a pretty strong one, is an IPL or a BBL. The chromophore is going to be the pigment in the hair. So what I've seen that it does is it actually kind of just makes the hair smooth, not as coarse. And of course, again, you have to have color in the hair to get it. If they have white hair, it's not going to do anything. If they have blonde hair, it's really not going to do much. It needs to be dark, and the more coarse it is, the better it picks up the energy. But your end goal is to have follicular swelling and redness, and you want to treat it during the anagen phase. So you don't want to tell people it's permanent hair removal, because it's not. You're not going to get rid of all the hair in that area. Chances are you're going to reduce a lot of the hair follicles, but unless you get lucky and get them all in the anagen phase at one time, you're not going to get rid of all of them. But what it does do is it softens the hairs that are there, and they're not as coarse as they were. Same thing with tattoos. You can do it like every 6 to 8 weeks, again, to catch the hairs in the growth phase. And also, it's going to take, this says 6 to 10 treatments. Realistically, depending on how much hair they're trying to get rid of, but also how much the patient can stand at one treatment. Because if you can chill them really well, you might be able to not have to do as many treatments. I find that doing hair is probably the easiest thing for me to treat, because I just ice the heck out of them, and then you can put more fluids or more heat on them and treat them. But you want to really get them to where you have perifollicular edema, because if you don't see that, you should be raising that fluence up, because you're not affecting down to the follicle. And this says sensation of light sunburn. Again, that they'll be red just by the fear fact putting the heat on them, but I can't stress to you enough the perifollicular edema. That is your goal you're looking for. Benefits of laser surgery. Reduction of post-op pain. You need to know that. Reduction of bleeding and swelling. And a decrease in the chances of post-op infection, but it also reduces the operating time and decreases hospitalization stays and medical cost. So laser safety. Know that OSHA will come to your office. If they haven't, they will eventually. And if you have a laser in your office and you don't have a sign up, they will cite you. The other is just pick a person who's your laser safety officer And make sure you take a class so that you can say you're the laser safety officer, because they'll ask you those questions. And that should be in your policy and procedures in your office of who that person is. So eye damage, it can happen, and I am actually aware of 2 cases in a hospital locally that it actually happened from reflection from the tools. They didn't zap it or actually get it in the person's eye. It reflected off of some of the tools in the OR. So you need to make sure that everybody in the room, including the patient, has optical coverage, and you need to be aware of the wavelength that is being used and use the proper glasses, because the coating on them is based by the wavelength. Just any old pair won't work, because if you have an IPL and then you have other lasers, your IPL one is not strong enough for your lasers. It's not going to cover it. It's measured in optical density, and that's how they know based on the wavelength. And for patients, it's kind of freaky for them to have eye shields put in, especially for you if you've never put them in. So if somebody's claustrophobic, you really have to kind of hold their hand while you do it. But we actually put topical numbing in so that they don't feel them as much. It doesn't bother them. And most of the patients have told me, they said that makes all the difference in the world. And just be super careful from the thermal and burns and inadvertent application of the laser beam with the burn from a laser reflecting off the shiny objects. Endotracheal fires, oxygen, and with the plastic from the tube, they can cause combustion. So be super, super careful if you're in an OR that uses lasers. Watch those tubes. The anesthesiologist is usually pretty good about keeping an eye on that, but you know we're usually the other set of eyes. And I'm usually pretty bossy when I'm in the OR. So a beam can ignite flammable material like a gown, sponges, drape in an ET tube. And this goes without saying, but water and electricity don't mix. And the same goes for the electricity with a laser. They don't mix. So make sure that all the power cords aren't frayed and there's no liquid that drips near the power source to your laser. I just mentioned earlier about the smoke plume when you're doing warts, and you really need to make sure that they're not using a wall unit. This isn't so much in the OR. It's more in an office setting, especially if you're doing hair removal. There's a lot of plumes with that. You're not as worried about getting an infection from that, but it's toxic gas. So make sure that you have a smoke evacuator in the room and use it. I can't tell you how many offices or friends that I have that they're like, yeah, I never use it. You don't want to be breathing that junk in there. A laser splatter is when you actually are doing a Q-switched laser and there's an explosion of blood and skin fragments from the tattoo removal. And it usually is because you had this setting, it was too fast, which means your pulse speed. So you need to be very careful of those settings. And again, that's why you want to do a patch test. So hopefully you can avoid this, but sometimes it's just, it's a side effect that can occur. But you need to make sure when you're doing any of the Q-switch that you sterilize the nozzle between uses. because even if it's not an obvious one, I mean, they're not going to explode right in front of you, but it might be very small ones. And you can get microscopic droplets on the tip, so you want to make sure that you sterilize it between patients. Install signs that say danger in the wavelength on your doors and cover your windows. And that's more, again, for a hospital setting, because if you have windows on the outside of your office, usually there's not peeping Toms coming up and peeking in your window. But if you have doors that have windows, you should have those covered, because those laser beams can go through the doors. And you need to have that sign. Like I said, if OSHA comes and you don't have signs and a laser, they're going to cite you. I actually have mine in a folder, and I have a little pocket by my laser. So my signs are right there, so nobody has to go looking for them. They're right there with the laser. And you need to, again, like I said, use the smoke evacuator and check your filters prior to the procedure. Make sure that they're actually clean and they're working, that they are actually going to be able to evacuate the smoke. And keep some water and wet towels available in case there's ever a fire, so you can throw some water on that. And the key that goes into the lasers, take that out when you're done, because that's like leaving your car keys in your car. Somebody can jump in and take it. Somebody in your office that's going through, and not your staff, but if somebody has a child in there, or even a patient just wants to go by and turn it, they can turn it on. There's not a passcode for most of the lasers that I'm aware of. That's your passcode. Patient assessment and preparation. So again, you just need to identify the indication. What are you going to be treating? What's their Fitzpatrick? Do they have a history of fever blisters, and have they been using Accutane? If they've been using Accutane within the last 12 months, don't do a treatment on them. Their skin is too fragile to be able to do a treatment. You need to know the medications they've been taking. Again, if they're on anything, and a lot of the antibiotics make them photosensitive, you're going to have to lower your fluents, because it is going to make a difference on how much energy you're going to put in them, or you're going to burn them. And recent tanning. Treating tan skin can lead to hypopigmentation. And it can be a spray tan, or it can be a natural tan, and it can also be those injections. Now, anything that's going to cause an increase in production of melanin is something that you need to be aware of. Patient counseling. Pre-treatment with hydroquinone 3 to 4 weeks prior to treatment to reduce PIH risk in Fitzpatrick, 3 to 6 people. Fitzpatrick. If you put them on hydroquinone and you have them on it for 3 to 4 weeks, you do not abruptly stop the hydroquinone after 4 weeks. You have to taper them off over a period of a couple of weeks. You cannot just abruptly stop it. And you need to pre-treat with antibiotics or antivirals as needed. And again, if they've been on Accutane in the last 6 to 12 months, don't treat them. I actually will do it 12 months, and I think most things that I see say 12 months. And let them know that there's going to be erythema or like a sunburn after they have a non-ablative treatment. It's usually about a week, and if it's an ablative treatment, it can last up to 12 weeks. Anesthesia. This is a big controversial. I do know people that use topical BLT when they do laser treatments, but don't ever occlude an area with saran wrap if you do, because it can lead to lidocaine toxicity. And only put it on for 30 to 60 minutes, and you don't want to treat more than 2 cosmetic areas at a time to avoid lidocaine toxicity. I would recommend that you be aware of what the signs and symptoms are of lidocaine toxicity, because you probably might need to know those on a test. But it usually has to do with neurological symptoms. So prepping the patient again, just completely clean the area. Make sure you have all makeup off there, because when we said tanning, the makeup where a lot of people put on the waterproof makeup, it's really hard to get off. If that makeup is still on there, that's considered tanning. You're going to burn them. So make sure that your patients know when they're coming in for a treatment to not wear makeup, but I don't trust them. I still get a woven gauze and alcohol, and I wipe them down. Number one, to degrease them, but also to make sure that there isn't any residue. And if there's any residue, I keep wiping till I don't see any, because you do not want to take the chance that there's any pigment from the makeup on them. Don't use Hibiclens, and it says never around the eyes, and that's because of scleral burns. I know when you see people injecting on the podium, or you see YouTubes or whatever, I used to cringe when I would see that, because it's not something new. It's always been that you should not use Hibiclens around the face. I think it's since dermal injections came out that people started using Hibiclens, but even the company has told us for years that it shouldn't be used around the face. So again, use either the hypochlorous or alcohol. Don't worry about the others, but obviously if you're doing a type of laser, you probably would want to use the hypochlorous. IPL, you can use alcohol, but with a laser, alcohol is flammable. So post-procedure care, you need to make sure that they wear sunblock and they wear clothing that's going to cover them up, and also a visor. And if they have wound care with a tattoo or ablative, make sure they have antibiotic ointment. And then if it's an ablative laser, you can actually make a mix with vinegar rinses or use Aquaphor or Vaseline. And then closed dressing technique, you can use the Flexon or any of the silicone membranes, but just make sure they need to stay out of the sun. I usually tell them, think like you're a brand new baby. You have brand new skin, because literally they pretty much do if they've had any type of ablative or non-ablative, and they've already got heat in their face. And if you add more to it, it's going to hurt. Number one, they're probably not going to want to be in the sun, but they're just going to add insult to injury. Potential complications: erythema, edema, and hyper and hypopigmentation. I don't consider erythema and edema a complication. That's kind of an expected side effect of it, but hyper and hypopigmentation can be. And the hypopigmentation is actually more common in darker skin. And also you can get texture changes, scar, and localized allergic reaction with certain tattoo colors. It depends on the irons and the different metals that are in the tattoo, and a lot of times it can actually cause a reaction. And that dreaded red dye, it's the same thing with the red pigment, with red and green. I think it's red and blues and purples. There's pain, crusting, burns. Acne can actually happen after a lot of the ablative procedures, and they don't really get the cystic acne. They'll get like milia. So let your patients know after they have light therapy that it's not unusual for them to get milia, because they're coming into you to get their face cleared, and all of a sudden they have pimples they never had in years. So just let them know. A lot of that has to do just from the dead skin or the extra Aquaphor stuff plugging up those pores, that it is going to subside over time. And also the weak lower lid in the canthal support, they're going to have more of the ablative treatings down here, like an erbium. That seems to be where I see a lot more of the little milia, and because that skin's so thin, it drives them crazy, because it's really more obvious. So non-ablative lasers and light-based devices, remember, there is no vaporization or removal of skin. There's not an open wound. An IPL or BBL, they're both the same thing, BBL, I think, is just specific to one company, but IPL and BBL is filtered light, and they're the same thing. Non-ablative fractional resurfacing lasers. And IPLs diffuse targets, and they prefer pigment more than anything. Lasers like defined targets, and they prefer vascular or water. So what's the difference between a laser and an IPL? Lasers are defined as devices producing a single wavelength seeking a specific target in tissue. Remember, that's what we said when we first talked about what is a laser. IPLs produce a broad band. Again, that's going to be easy to remember. BBL, broadband. So IPLs and broadbands are the same thing, and they are between 400 and 1300 nanometers. The higher the filter number, the less melanin absorption. The IPLs and the BBLs, so this is a BBL that you see a picture of because they can actually just change with little, it's one hand piece and they put different filters on it. With most of the IPLs, it's separate hand pieces for a specific wavelength. So depending on the hand piece or filter, the chromophore can be, again, the same thing with the lasers, an oxyhemoglobin, pigment or melanin, hair follicles, but you can also target P. acne and then water to induce neocollagenesis. So IP applications can be done for vascular treatments with rosacea, pigment, hair, acne. The ultraviolet and the purple wavelength are very similar. So when you do an IPL, if you get a purple wavelength, you can actually treat the P. bacteria, and it works pretty good. Poikiloedema of Savate and melasma is not a good choice. Melasma is very difficult to deal with. If you've done chemical peels or anything, it's a very teetering thing. And melasma just doesn't seem to work really well with IPL. It works better with regular daily skincare and maybe gentler peels, but the IPL, the heat, doesn't seem to really help it. The advantages: minimal downtime. You're not ablating the skin, and again, it's scattered light. Combo units that offer light and laser are pretty, if you can get a machine that does both, you can just switch out the hand pieces, which lasers you usually can't. And then there's usually a series of treatments that they need, so you need to let the patients know that it's kind of rare that one treatment is going to take care of whatever their issue. So it's pretty common that they have to buy IPL packages or BBL packages. Light emitting diodes are, we refer to them as LED equipment. And it's a panel of small lamps that emit low intensity light, either red or blue. The mechanism of action, it's non-thermal, and it's to increase collagen, promote wound healing, or destroy P. acne. It's real great for inflammation. And then the contraindication is the photosensitizing meds, which you need to be careful if they're on antibiotics, but a lot of your acne patients are on them. So the derm, you're going to decide. You know, you just have to really watch them to be careful, but for the sake of the test, it's a contraindication, but it's not unusual to see somebody on minocycline or doxycycline and have them in for blue light therapy, even red light now. Photodynamic therapy. Is there anybody in here that does PDT? Love it. A lot of people are afraid of it, but it does wonders on the skin. Again, you can activate it with the IPL, but you can also use a blue light, a KTP, or an LED. And what it does is it causes the protoporphyrin 9, and it causes cellular destruction. So I usually refer to it as chemotherapy for the skin. Common side effects after this treatment are pain, irritation, extreme photosensitivity. And when I say extreme, I usually tell my patients to think like they're Dracula after they have the treatment, because you cannot go in the sun. Even high UV lights in an office or in the home can continue to stimulate it and just make them more hot and actually burn them a little bit more. So physical sunscreen is a must. Just putting on regular sunscreen isn't going to cut it. Most of the time, they need to have somebody drive them home, so that, especially because they're doing their face, they need to cover with a scarf. But I usually send them out with a hat and then a scarf covering them up. So all you can see is just this. Non-ablative fractional laser resurfacing. It's not in yellow, but it's in red, so I'm not sure if it's something you need, but just to be familiar is the microthermal treatment zones. You may see MTZ. It's columns of thermally denatured skin with controlled depth and width into the epidermis or the dermis. And the stratum corneum is left intact, and areas of thermal delta surrounded by areas of untreated tissue, they just heal faster. And usually these patients are red for 3 to 4 days, as opposed to if they had a full CO2, they might be red and ablated for like up to 12 weeks. Again, water is a chromophore, and damaged skin cells incorporated to, again, MENS is the term that's used. Most people don't, it's the acronym, but it's for microscopic epidermal necrotic debris. And it's shuttled up and out of the skin. So they basically have to slough it off. And again, they can get acne eruptions as the debris leaves the skin post-treatment. So let them know they're going to have breakouts. Non-ablative laser resurfacing application, you can use it for fine lines and wrinkles, scars, acne. It can be used for surgical and stretch marks, hyperpigmentation and melasma, AKs, poikiloderma cavitae, and it's also safe for off the face. Again, remember the ablative, you have to have the hair follicle there. So non-ablative laser resurfacing, what are the advantages? Pretty much all skin types safely, as long as you pre-treat the darker skin with the skin lightening agents. And there's mild to moderate pain. It's really not that uncomfortable. Minimal healing time, again, is in 3 to 4 days. And you pre-treat patients that have any cold sores. The disadvantages are topical anesthesia and or cooling device. Again, I don't use topical anesthesia because I don't want to blister the patient. I need their feedback. So I usually give them a cooling device. If you're doing the treatment for rhytids and you're going for neocollagenesis, you don't want to cool the skin too much, because then you're going to not get the collagen stem that you're looking for. So there's a fine line between it. But my guide, and it keeps me safe, is that the patient's feedback to me is the most crucial. I need to know if they're in pain, because that tells me I need to turn the fluence down. Sorry about that. What are the contraindications? Obviously, active infection, pregnancy, lactation, and again, this is Accutane within the last 6 months, and then patients' unrealistic expectations. Post-procedure, ice, ice, ice. That's when they can have plenty of ice. Get that heat out of there. Make sure they use gentle cleanser and sunscreen, and they're not using their retinoids or any of their harsh pre-skincare stuff until they re-epithelialize, because they're not ablative, but their skin is sensitive, and if you used a fractional, there could be some tissue, but they're definitely too sensitive to be using anything too aggressive on their skin. Make sure that they get their Valtrex, and again, there's a chance for post-inflammatory hyperpigmentation, so keep an eye on the patient. What I've learned is if you ice them and keep them cold, and them giving you that feedback, the chance of PIH is almost nothing. Skin tightening devices. So the chromophore for those is water, and it's an initial collagen contraction and destruction through both mechanical and biochemical pathways. You can get collagen remodeling through a controlled wound healing response. So it goes through the algorithm of neocollagenesis. It basically works on the wound healing cascade. Initially, you'll see tightening, but it's short-lived, and the patients are really bummed because they're like, I looked really good right after my treatment, but I kind of look the same as I did, but they'll start seeing more results at 6 months once they get that neocollagenesis. Again, in these treatments, super important to make sure their skin doesn't get overheated to avoid burning and blistering. And you can actually there's some IPLs that will get to that level wavelength, and infrared light and radio frequency. Most of the patients that you pick for this, you really have to be careful that you give realistic expectations. The right patient and the right fluence are going to give you beautiful results. But if you've got areas with a lot of skin laxity, without a great deal of muscle attachment, they seem to have a better response and better tightening. So think about the neck. If you've got somebody that's got obvious platysmal banding and a lot of platysmal redundancy, if you tighten that skin and the muscle's not attached, they're still not going to be happy with the result because they're still going to have this. And it's actually sometimes makes it look worse because you've tightened the skin and it makes this area in the submental area more obvious. So patient selection in these treatments are super, super important. And let them know they're not going to see the results overnight. It's going to take several months. Okay, so Thermage is a monopolar radio frequency. And what it does is it's got a cryogen cooling system to protect it. Some people do treat the eyelids. If you do, you need to put in the eye shields. Don't use any nerve blocks again in this area. You need their feedback. Pain is a warning to turn down your fluence. And I can't say that enough. Anytime I've had patients come to me that have come from somewhere else, when they're either uneven or I can tell that they've been burned, the first thing they tell me is it hurts so bad. It shouldn't hurt. It's not fun. I mean, I don't look forward to getting zapped, but it shouldn't hurt that. It shouldn't be really, really severe pain. It's contraindicated in patients that have a pacemaker, an internal defibrillator, or any metal implants. So bipolar radio frequency, it's not as effective as monopolar because it doesn't produce the volumetric heating. And a major adverse event with this is tissue arcing, which can occur and lead to scars. Infrared skin tightening, that's to tighten the skin tight, the Starlux. It's best used over where there's loose skin but good structural support. So if you, again, have someone that doesn't have a good structure underneath and they don't have contouring, pulling back is just going to make them look worse, or you're not going to get any tightening. The wavelength on this is 800 to 1400. And again, you need to cool, cool, cool on the face and the body. So Ultherapy, or Ulthera, is ultrasound skin tightening, and it's an intense micro-focused ultrasound device that allows for visualizing the skin and deep tissue. The ultrasound isn't what, you can see the ultrasound on the diagram on the picture over there, and basically you can see when you do the treatment where your wavelengths are going to. So it delivers therapeutic zones of thermocoagulation, and it can go 3 to 4.5 millimeters into the skin deep. There's no downtime according to this. And there is possible bruising, tenderness, and lack of sensation. Very uncomfortable treatment. Patients oftentimes complain of significant discomfort during the treatment. And it is the first FDA-approved lifting of facial dermal tissue and deep subdermal in the SMAS. It's usually better on people under 50, again, because they have a better foundation and they don't have the laxity in the muscles. It's not so great over 50. And usually about 2 treatments are needed. Contraindications are open wounds, cystic acne, metal stents and implants, implantable electrical devices such as a pacemaker. So make sure you know those. Fat-reducing devices. There's even more on the market, but right now we're just going to go over the ones that are in the book. So there's ultrasound, which is liposonics, cryolipolysis, which is cool sculpting, and also a machine that has diode lasers on it. So liposonics it heats up the subcutaneous adipose and it contracts it. The treatment zones are resorbed in 8 to 12 weeks with fat reduction up to 1 inch. So before you do a treatment, you need to be able to pinch at least 1 inch of the skin. Otherwise, they're not going to really see any result. And there's bruising, edema, and tenderness for a couple of weeks after. And the contraindications are if somebody is over 30 BMI, chances are a lot of that fat is visceral fat and not sub-Q. This does not treat visceral fat. Other contraindications are large scars, wounds, hernia, pregnant, less than 1 centimeter of adipose tissue beyond treatment depth of 1.3 centimeters. Again, that is the visceral fat that we're talking about. You can't get deep gut fat. Cryolipolysis is the opposite of the other. This is actually cool sculpting, and it causes apoptosis or death of fat by freezing the subcutaneous fat. And the hand pieces actually, except for one of them, a vacuum draws the tissue into the applicators, really cold hand pieces. And the procedure lasts about the treatment actually with the handpiece on lasts either 35 minutes to 75 minutes based on the handpiece that you're using. And when a patient comes in to be assessed, again, they're the same as the liposonics. If they've got visceral fat, this is not going to treat it. Usually with cool sculpting, they say if you can squeeze it, you can freeze it. It's FDA approved for the abdomen, the flank, and the back, but it's used in a lot of other areas off-label. And let the patient know that approximately 20% of an area that's being treated will have the apoptosis or death of that fat cell. And a lot of the patients don't understand, and I tell them, no, it's killing them, but it takes about 3 months to see the end result. Usually, they won't see anything the first month. It's extremely rare that they'll see anything. At second month, they might start seeing something, but they're going to get their end result and know really what their outcome is going to be at 3 months. It's not uncommon to have several cycles, which means, or treatment times, They're going to need to come back in about 8 to 12 weeks and have another treatment done. And if they have another treatment done, it's not 20% of what they started with. It's 20% of that treatment area that they're getting. Side effects can be bruising, swelling, temporary altered sensation, numbness, or sharp pain in the treatment area lasting up to 2 weeks. And that's not unusual for the altered sensation and maybe numbness, but there shouldn't be sharp pain, and sometimes there is bruising, but it's rare that I see swelling. Contraindications are Raynaud's, impaired circulation in the treatment area, diabetic neuropathy, open wounds and bleeding disorders, also recent surgery, scar tissue or hernia in an area, and then pregnant or lactating. One other thing I want to mention, it doesn't say it on here, is you need to make sure that after the patient has the handpieces taken off, that there's really aggressive massaging for 2 minutes in the area, because the studies have shown that if there's not aggressive breakdown of that ice and cold area to let the blood circulation go in, it has a significant outcome, reflect on the outcome. So with the cryolipolysis, there has to be massage afterwards. The diode laser is the Zerona, and I don't see which year this was FDA approved, but it's not really out, not a lot. Does anybody here? Yeah. So there's 6 simultaneously rotating laser beams that it does circumferential reduction of the waist, hips, and thighs, and it's cleared for non-invasive reduction of upper arm fat. So remember we said there were different mechanisms, actions for lasers. So this one is actually the photochemical one, and it's stimulation to disrupt the membrane of the fat cells. This one is considered a cold laser. It's a 635 diode, and basically with this, as opposed to the other two, they kill the fat cells. This one only shrinks them. It doesn't kill them. So you're not going to, they basically, when they have the treatment done, they're going to have some shrinkage, but there's no guarantee that, you know, when they gain weight again, they're going to blow back up. Whereas with the others, if they gain weight, those fat cells that they have remaining can blow up, but they don't come back, they're gone. You do need a series of 6 of these, and they're 20-minute sessions over a 2-week period. Okay, we survived the light therapy and the lasers. There's wine in the back. We're going to go on to sclerotherapy. So you saw with the different lasers that a chromophore is oxyhemoglobin. Not so much on the legs, though. I mean, there are lasers, and some people do laser treatment for veins, but it's more for the deep vein, and they actually insert the probe, so it's done more surgically as opposed to the superficial cosmetic ones. The gold standard for superficial ones is sclerotherapy, and it's used to treat the reticular and the telangiectasia. So this is just kind of an overview of the anatomy of the lower extremity, the venous system. The deep veins are the femoral, the popliteal, the anterior tibial, and the posterior tibial, and the perineal, and they are responsible for 90% of the venous return, and they run parallel on the legs. And you can see the superficial. They originate in the skin, and they lead into the reticular and feeder systems, which then merge into the deeper veins, and they distend under pressure. So they are affected by temperature and from hormones too. That will have an effect on those vessels. The perforating veins or communicators connect to the deep ones to the superficial, And just FYI, the great and saphenous veins are part of the superficial system. So what are telangiectasia? They're the ones that a lot of people refer to as the spider veins. They're going to be fine and feathery and flat, and they're usually a reddish hue. The specific measurements, and that's how they get differentiated from the reticular, is they're 0.1 millimeters to 1 millimeter. And again, like I said, they're generally flush with the skin. And patients, they can have itching in the area, but it's rare. They're more cosmetic. They don't usually have any discomfort or pain from them. Every now and then they might, but it's extremely rare that I ever hear any complaints from those causing it. Now, they might tell you they have aching or pain in their legs, but chances are that aching and pain, those telangiectasia, are actually caused by problems with the deeper vessels. So if a patient comes to you for sclerotherapy and they say the word pain, you probably should refer them to a vascular specialist, because if you treat these and you don't treat the cause, these are going to keep coming back. And they do come back anyway, but they're going to come back a lot faster if you don't treat the cause. So these vessels are actually, they're a lot more ugly than just the spider veins, and they're usually darkish blue. And then what differentiates them from the reticular is they're smaller in diameter. They're 1 millimeter to 2 millimeter, and they're usually elevated. And you can see those in a lot of diabetics or a lot older people. And they're much more obvious just because of the color. They're just really dark, and they're raised a little bit. And the reticular veins are the feeder vessels. Again, we were talking about between the deep and the superficial. And they're 2 millimeters to 4 millimeters. So that's how you're going to know the difference between them and the others, again, is their diameter. So in this picture, you can see the comparison of the spider vein and the reticular. Some people, you'll see their reticular veins and they won't have spider, and that's normal. I wouldn't treat those. They've just got thin skin. I do have some people that come to me and they're like, I don't like these. I'm not comfortable treating them. That's not my issue. If they have a reticular and they have spider veins, then I will treat it, because that reticular has caused them to have spider veins. And these are usually, they just look cyanotic. So patient history is important. It's not hereditary, but it's familial. So the mother may have telangiectasia, and maybe one of the daughters might, but the other one might not. So it's more familial. A lot of it, though, has to do with lifestyle. If you're overweight, your occupation, if you're standing a lot or sitting for a long time, that seems to precipitate it and lead to it more than just genetics. I see the genetics more with people that have the reticular. I don't see it more with the telangiectasia and with the varicose veins. But it can also be attributed to hormones and hormone therapy, pregnancy, obesity, if they've had a history of blood clots, and history of diabetes. And it doesn't say it on here, but one of the things that I see a lot is when I'm getting their history, is they had a history of an injury in the area. And they may have had like a hematoma or a bad bruise, and they ended up getting telangiectasia there. A lot of times I hear from women, either they got hit in the leg or they bumped something, and it's either on the shin or it's over here on the thigh area. Physical assessment, visual inspection of patterns, Doppler exam, which if you're doing vessels, I think you should have a Doppler, because again, If the problem is deep, then you're doing cosmetic on sclerotherapy on the telangiectasia isn't really going to help. They're just going to come back. Standing exam, you should have them stand, not just sitting and laying with their legs elevated, but you should have them stand up, because some of them aren't as obvious when they're sitting down. When they stand up, you definitely will see more of them. And you can check to see if they have, edema in the area. You want to check their pulses, their pedal pulses. You need to document the strength of those pulses. And then if they have any scars or ulcers in the area, if they have ulcers in the area, chances are, again, it's probably deep vein issues, and refer. Patient education, they need to know it takes multiple treatments. When you do the first treatment, they'll get clearance, but there's going to be, I call it cleanup. You'll get clearance and you'll lighten some of them, but I tell my patients count on minimum of 3 treatments. After the second treatment, they look a whole lot better, but the third treatment usually clears it up. And then just like laser hair reduction, the same thing with this, they're going to get them back again. They won't come back as bad as they were, but I usually tell them it's maintenance. They need to make sure that they maintain and come in if they want to keep them cleared. A certain amount of the treatment success is dependent on their post-care. They need to wear those compression hose, and they need to not be sitting too long. So if somebody comes to you, and there might be a question on the test, you have a patient who comes to see you and they're interested in sclerotherapy and they have telangiectasia, and they may ask you which solution, which we'll get into some of them, but they are planning on going on a trip. Would you recommend they delay the treatment, or would you do the treatment, or whatever? So those are kind of test questions that you might get, because the biggest thing is they need to walk after the treatment. Walking is the best thing, number one, to help with their circulation, but also to spread the sclerosants through the vessels. So the different sclerosing agents are in different categories, and you want to choose the agent with a minimal concentration and volume to lessen the chances of an adverse event. But again, you want to use enough that's going to actually do something. It's kind of like lasers. If you use too low of affluence, you're not going to get a result. Well, if you use a sclerosant that's not strong enough, it's not going to do anything. You might as well just be injecting saline. But if you use one too strong, you can actually cause a complication we'll talk about in a little bit called matting, and you can actually add more telangiectasia as opposed to getting rid of it. So there's detergents, there's osmotic, there's chemical irritants, and your end goal is just to endothelial damage to the vein wall, and it leads to fibrosis, and it obliterates the vein. So detergents. Sodium sotradecol is FDA approved, and Masclera, which is polydocanol, is FDA approved. Then 2 other sclerosants, there's Scleromate and there's ethimoline. I'm going to get into these, but those are not FDA approved, so you need to be cautious of using them, because if you use them and the patient has an adverse event, you're using them off-label, when there's ones on-label you could be using. So keep in mind FDA approved medications. So the sotradecol is FDA approved for sclerosing leg veins, and it's basically just a surfactant. It's soap. You can get it in 1 and 3%, but notice the red. The 0.25% is for 0.1 to 2 millimeter spider veins, and 0.5 is for 2 millimeter spider veins. So they only sell it in 1% and 3%. You have to dilute it down to get it to those so that it's not too caustic. So when you're looking at your spider veins and your solutions, if you have a patient and you're not sure how much do I need to use to get them cleared, go on the more dilute side and see what the reaction is. When you inject, you'll see a bright red color. If you diluted it down and you get the bright red, that's strong enough for that treatment. You don't need to go stronger. If you don't see a bright red, then you can go ahead and maybe make it a little more concentrated. But this is a general guideline for that product. Asclera is distributed by MERS, and it got FDA approved in 2010. And again, this one comes in 0.5% and 1% solutions, and it comes in ampules. We don't use a lot of ampules anymore, but when you use an ampule, you might want to use filtered needles, because there is a chance that tiny little particles of glass can get in that liquid, and you're going to be injecting in a vein. So filtered needles are recommended with that. And this product is actually, there's not pain because it's actually a non-ester local anesthetic. So it's very comfortable to inject and be treated with. There are possibility of hyperpigmentation anytime you do any sclerosants, actually. And the maximum recommended volume per session is 10 cc's. And you can see the different strengths in the pictures in the boxes there. So both of these, the detergent types, they can be foamed. And why would you want to foam them? Well, if you have vessels that are greater than 4 millimeters, it actually helps keep the solution on the walls to cause that cascade of destruction. And it's more economical. You don't need to use as much. If you foam it up, it's going to move a little bit slower and it's going to expand. So it's not going to take as much liquid of the medication to go through there. And the blood dilutes the sclerosant, so foaming is more concentrated and it's not as easily diluted. Therefore, it is more potent. So these just kind of show pictures of how you foam it. You literally just swish it back and forth and the air gets in there and makes it bubble up. They're using ultrasound guided, in this picture here, because you want to see where that foam is going. And then that's a picture of the foam just kind of dripping down. This one is, I don't know why anybody uses it when you read all the negatives about it. It's not approved, and it even says in their PI that it's not approved for leg sclerotherapy. It's indicated for the treatment of patients with esophageal varices, and they have recently had a bleed. So their product website says the practice of injecting varicosities of the leg with this product is not supported by adequately controlled clinical trials. Therefore, such use is not recommended. So, another type of sclerosing agent is an osmotic, and sclerodex and hypertonic saline are used, and the hypertonic saline is 23.4%, and many times it's diluted down with lidocaine or saline to bring it down to like 17% or even less. Like I said, you kind of check to make sure you don't have too strong and you dilute them down. It is rapidly diluted in the bloodstream, and they lose their potency within a short distance in the injection. So it's really popular because it's super cheap and it's readily available, and there really isn't a chance, it's really not an allergic reaction to it because it's hypertonic saline. And you do get a really quick clinical result. You can see the vessels turn red. I mean, as soon as it passes through, you can see redness within a very short time. The cons of it is, though, that there's a lot of post-injection pain and muscle cramping, and there's a high incident of cutaneous necrosis if you get it outside the vessel. It's very, very caustic to this tissue. And there's a higher increase of an incidence of hyperpigmentation just because of the hemolysis, the red blood cells, and it does leave hemosiderin staining in there. And even though it's an FDA-approved medication, it's not FDA-approved for sclerotherapy. Chemical irritants. They damage the cell wall by direct caustic destruction of the endothelium, and they act as a corrosive. So glycerin, chromated glycerin or Scleromo is an example of one. It's not very strong. It's really considered pretty weak, and it's not FDA approved for sclerotherapy on the legs. It's really good for small vessels, again, because it's not really strong. And there's minimal complications post-treatment, but it's very, very thick, and it's painful. So a lot of times they'll dilute it down with lidocaine, and it significantly reduces the pain and the bleeding. And the lidocaine is usually 1% epi in it, which sounds crazy. You're putting lidocaine with epi in the vein, but there's a lot of bleeding after using this. So you can actually get hematuria if a lot is used. That's one of the side effects of it. So what are the sclerotherapy contraindications or pregnancy and nursing? If they're non-ambulatory, they can't get up and walk around to help that circulation. They have a higher chance of having skin breakdown and more complications afterwards, so they're definitely a contraindication. If they're on anticoagulation therapy, it's obvious why you wouldn't want to do it. You want them bleeding. Thrombophlebitis, they already have inflammation going on, and you could actually make it worse and have more complications in other areas. And then if they're allergic to any of the sclerosing agents or the ingredients that are used to make it. So how do you do this? You start proximal, and then you treat the larger veins before you treat the smaller ones. If you don't treat the reticulars, like I said earlier, and you have the spider veins, you're kind of going backwards. So start with the reticular, because a lot of times you'll see the spiders disappear when you inject the reticulars. Biggest thing to avoid matting is slow and precise injections. I can't tell you how slow you want to be, because the faster you go, the more pressure it puts in, and it traumatizes the vessel. And blood vessels are smart, just like nerves. They can regenerate. So if they sense an abrupt injury, that's the stimulation for more vessels to develop, and that's where the matting comes in. Pain is a sign of extravasation, and if a patient, when you're injecting them, they tell you they hurt, stop. Also, when you inject, because you're injecting very slow, you'll see a white area if you're not in the vessel. And some of those little tiny vessels you might get a few little white blebs. So those are not going to have a lot of healing issues. Every now and then they might be like a little blister, but it's not if you had put a whole large amount in there. So I can't express enough to you that slow, almost just little drops. And those vessels are so tiny that you'd be surprised how many areas you can treat with just 1 cc. When you're taking your needle out, you want to put cotton balls right over where your needle came out. And the reason for that is so that you don't get a backflow of that fluid, and it doesn't cause tissue damage to the tissue that you've just treated. I would recommend having your cotton balls with pieces of tape already on them hanging on your Mayo stand, so that as soon as you pull your needle out, you can put compression on that right away. Also, there's been proof that if you compress the vessels, they heal a lot faster, and there's not the complications or risk of as much for the hemosiderin staining and the cramping. Then when you're done, put your compression dressing on, and it does not have to be the compression hose at first. I use cling wrap on my patients when they first come in, because I want to make sure they stay in place. Support socks fall down, so if you do use support socks, have them measured and have them bring them into you, but make sure that they go to a surgical supply store and buy them there, not just go get support hose, because they have to be a certain strength. And a lot of people don't realize that. They'll just go to like the pharmacy, or they'll go to Target and buy support hose, and so they need to know that they have to have special ones, which is why I do the compression, because I know I want to make sure that I have enough compression on there, and if they bring the wrong ones in, then I'm risking the chance of not putting compression on them. Graduated compression hose, worn up to 2 weeks, and they literally will probably decrease the chances of DVTs, hyperpigmentation, and edema. And again, ambulation is mandatory after treatment. A lot of patients think they can go home and they should be, taking it easy and elevate. That's the worst thing they can do, because number one, elevating, they're obstructing the blood flow in the femoral area, and you want them to be standing up more than sitting, and walking just helps with that circulation. And follow-up appointments in 4 to 6 weeks. I see mine earlier just because I want to make sure that they're wearing their compression socks. So I'm kind of like a cheerleader for them to make them keep doing that. So I usually have them come back in like 3 days, just so I can take the cotton balls off, check all the sites just to make sure that there's no wound issues. And then that's when they bring their compression socks on, and I show them how to put them on then. They're hard to put on when they have cotton balls. So what are the complications? Hyperpigmentation is usually when there's larger vessels, is a higher incidence. Allergic reaction, or urticaria and anaphylaxis, that's with the non-FDA ones. It can happen with the other, obviously, if they're allergic to the contents, but it's more for the non-FDA approved ones. The matting, again, I mentioned that several times, and it's just either the injection's too fast or the solution's too strong. And ulcerations are because the fluid leaks out and causes tissue necrosis. Sometimes you can get PIH if there's blood trapped in the area. Again, that's why it's important for them to wear those support hose, so that the blood's not just pooling and they're getting stasis. It actually is helping phagocytosis, get the hemosiderin out of there. Bruising and itching, I think that that's not really a complication. To me, that's a side effect. I see that a lot. They may get bruising. I mean, if that vessel and you inject it, they look ugly after. If anybody's planning on getting sclerotherapy in the springtime, discourage them, because they're going to be upset. They're going to start wearing, short stuff, being at the beach. The fall and the winter is a time to do your sclerotherapy treatments. There can be cramping, which again, walking is going to help with that. It's just going to perfuse more oxygen into those muscles and help get that oxygen circulating around in there. If they do get tissue necrosis, and you'll see like a spasm, you need to be prepared that they need to have massage in that area right away. It's almost like a vascular accident with a filler. You need to put topical nitroglycerin on it. There is no debate about it. This needs it. When you're doing dermal fillers, the debate is that you don't want the possible embolism to move. There is no embolism here. We want circulation in that area as fast as we can to avoid wound healing problems. So nitroglycerin is not debatable. It needs to be put on there. And then you can actually put 75 units of hyaluronidase in 3 cc's. And what that is going to do is it's actually going to dilute that solution down and help disperse it more. It's not going to stay pooled up in that area. Hyaluronidase is just used, well, it's the antagonist to hyaluronic acid, but it's also used to break down the hyaluronic acid in your natural skin cells, so it allows you to disperse liquid easier. So in this case, you would actually want to use Hylenex in the area and just massage the extra fluid around. But that shouldn't happen if you're injecting slowly. That shouldn't be an issue. So again, slow, tiny drops and gentle injections. We're almost there. We're on clinical skincare. Okay. The epidermis, I'm not going to go through the skin again because we went through it in the beginning. So we're just going to kind of go through the different areas where you need to pay attention. The stratum corneum, a lot of the skincare products, most of them work obviously on the stratum corneum. And you want to, a lot of the products you'll see when we start going through, want you to shed the stratum corneum so that you can get better absorption through that. The stratum basal is what maintains the epidermis, and it's continuously renewing the cell population. The primary function to sustain and support the epidermis, and it contains blood vessels, nerve endings, collagen, elastin, and HA. HA. Remember that. The papillary dermis and the reticular dermis, know the differences between those. That the papillary is the one closest to the epidermis, and it contains capillaries, collagen and elastin fibers, and pain and touch receptors. So the reticular dermis is 80% of the dermis. It's got larger blood vessels, and it's got the cross-linked collagen and the elastin fibers. The subcutaneous layer is the fatty tissue, and it basically provides cushioning and insulation. So daily skincare products. Every day, sun protection and sun avoidance are key to facial youthfulness. The UVA rays are what ages us, and they're deep penetration of the rays. The UVB ones are the ones that come on the top. They're not as deep, and those are the ones that burn us. A minimum of SPF of 30 or higher. You're going to see on another side it's 15. But I think it's the difference Fitzpatrick. So even the Fitzpatrick 6, believe it or not, should be wearing sunscreen. They can get skin cancers. And I said it the other day, and it's corny, but it's what I tell my patients. Any day that ends in a Y, you should have on sunscreen. If it's cloudy or not, you're still going to get damaging rays. So physical sunscreens are zinc and titanium, and they deflect. Chemical sunscreens are listed, and they absorb in 20 to 30 minutes. And you definitely need to make sure if patients are going to be using these, that they put them on before they go outside. Not put them on while you're on the beach or by the pool or whatever. Put them on before you get out to give them a chance to be absorbed, because they convert with heat. Antioxidants, they neutralize and protect the skin from free radicals. Vitamin C and E, coenzyme Q10, and green tea are examples. And there's different formulations, and they need to be a stable formula. You can see where the damaged skin cells are here, and then the antioxidants go in there, and they actually just kind of regenerate it. I always tell everybody those are vitamins for your developing skin cells. So retinoids and growth factors and peptides repair the skin, and retinoids are the gold standard, and they increase cell turnover, they increase the epidermal thickness, but they do cause redness, flaking, and irritation is very common. If a patient has too much redness, you tell them to skip it a day till it calms down. A lot of times my patients will say, that facial cleanser was burning my face. No, it wasn't. It's a retinoid, just back off it a little bit. A lot of patients have to build up to tolerance to it to be able to use it. Growth factors, cellular messengers, they initiate tissue repair, they regulate cell growth, and they stimulate collagen, and they induce wound reepithelialization. Peptides are like the new molecule of the future. They are used in combination with retinoids for greater hydration. They promote barrier function, and they increase ECM proteins, all of which decrease visible wrinkling. Common skin concerns are dryness, dehydration, hyperpigmentation, redness, and rosacea. So we'll go through some of these concerns. So with clinically dry is considered when 10% of the water content is deficient in the skin. And many moisturizers can actually decrease epidermal water loss. So they actually refer to it as TEWL. Ceramides are great for locking it in and keeping the water moisture in the skin, and they decrease the TEWL. Our best friend, hyaluronic acids in the dermis maintains hydration. Hyperpigmentation is caused by actually extrinsic and intrinsic factors such as sun, inflammation, and hormones. And the melanocytes are activated, then they increase the tyronase production, and skin lighteners inhibit the tyronase, which is why you use the hydroquinone for avoiding PIH. And then the tyronase converts the AA and the tyronase into melanin. So again, the hydroquinone is a tyronase inhibitor, and it prevents the formation of melanin. There are other products that either have to do with the keratinocytes or whatever, but the hydroquinone actually inhibits the formation of the melanin. So redness and rosacea, they're commonly together, but just because somebody has redness, it could be because their skin is thinned. The redness does not necessarily give you a diagnosis of rosacea, but if you have rosacea, you have redness 99% of the time. Systemic flushing, inflammatory lesions like acne, and triggers for rosacea, sun, hot weather, alcohol, spicy foods, and cold weather. Cold weather can actually do it too. Acne is caused by clogged hair follicles from the P. acne bacteria. And the most frequently used treatments are retinoids, peroxide, and salicylic acid. So when you're getting the patient's history, when you're doing skincare, you need to make sure that, again, Accutane was in the last year. They don't have any active cold sores. And have they ever had sensitivity to chemical peel compounds? And discuss compliance. Lots of teenagers, especially guys, come in with acne. And you can put them on all the treatments you want. If they don't use them, they're not going to work. And it's kind of a vicious cycle. They're in sports. Their hormones and their testosterone's up. They're starting to get facial hair. So their follicles are getting plugged up, but they don't wash. And so when they get a girlfriend, at least they do clean a little more. Also be aware of their Fitzpatrick classification, and that has a lot to do with post-inflammation and the PIH. A Fitzpatrick 1 and 2 are rarely ever going to get PIH. We don't have much pigment anyway. The more pigment the person has, the higher chance of PIH. And it's interesting because, before I ever got into aesthetics when I was younger and thinking about it, you always thought that fair skin was like super fragile because it burns easily, but it is more forgiving than a darker skin. It doesn't get PIH, it doesn't scar as bad, it doesn't usually get keloid. It's the more, after a skin Patrick, 3 can do a little bit tricky, but from 4 to 6, you really have to walk a tightrope. So relative contraindications for skincare treatments is actually if they have a history of heart disease, they should not have a phenol peel. It could cause heart arrhythmias. When a patient gets a phenol peel, they are put on a heart monitor, so you need to know this. Previous peel or microdermabrasion increases their risk of scarring, and PIH risk again is 4 to 6. Pre-treatment, post-treatment scabbing and uneven skin coloration may occur up to 6 weeks after a deep peel, and you can tell them that they need to wear a hat and sunscreen, and a lot of times they may need to have hydrocortisone cream over the counter just to put on, or antihistamines. Pre-treat with tretinoin again and hydroquinone 4-6 weeks ahead, so that you have them de-epithelialized, but then you have to stop it 5 to 7 days prior to give them a chance to re-epithelialize so you don't burn the heck out of them. And it is really important because if you don't pre-treat them, they're not going to absorb, but if you don't have them stop, they're going to be on fire during the treatment. So SPF of 30 or higher, and avoid direct sunlight and exposure at least 1 week following. I would say that's longer because the skin is still really sensitive for a couple of weeks. Main thing is tell them not to pick that loose skin or peeling skin, to either let it slough off, maybe by using Aquaphor or massaging, or to take a little tiny scissor and just clip if it's hanging, but not to pick it because they will end up with scarring. They can resume their tretinoin and any of their treatments once they're epithelialized, usually about 7 to 10 days they can go back on their skincare treatments, but tell them to do it gradually because they may have been using more retinoids previous, but they need to back off some because their skin's going to be a lot thinner. Potential complications are PIH, hypopigmentation, allergic reaction, acne, infection, and persistent redness and scarring. And never pass an open peel solution over the patient's head. I don't know why I have to say that, but I'm going to. And check the label. How is the acid neutralized and what's the expected outcomes? Always have your neutralizer there, and don't lay the patient down flat. Have them sitting up, and you want to start low and go up, because if you start up, it can be running down and you're actually going to be putting even more on them. And make sure you have water close by. So there's light peels, and it increases epidermal sloughing, and then there's deep peels that actually reach down and cause inflammation to the dermis. So here's the depths of the peels. You need to know this. The very superficial just causes basically exfoliation, and it just removes a thin layer of the stratum corneum, but it doesn't go down to the stratum granulosum. Superficial is an epidermal peel, and it removes part of the epidermis from the stratum granulosum to the stratum basal. So it goes down to like the 3rd and 4th layer, but it doesn't make it down to the dermis. And then the medium actually gets the upper dermis, which is the papillary dermis. And it removes all of the epidermis and then a part of the papillary. And then the deep goes down to the reticular dermis. And it takes off, obviously, the epidermis, the papillary, and then the reticular. So a TCA 35% is an example of a deep reticular peel. So there's salicylic acid in the Jesners, lactic and resorcinol. It's kind of a combination. And the nice thing about those is they see exfoliation in 8 to 10 days, and there's not usually any crusting or it's not a lot of recovery. It's usually an intraepidermal only. It doesn't go down to the mid-level. A medium depth peel is 10 to 50%, and it's usually used for fine lines and just refreshing the skin, and it can be used on darker skin. They usually feel warm when it's going on, so have a fan in the room. And some people, if they're prepped fine, They really don't feel any heat. You can usually tell the people that didn't prep well enough because they're on fire. The non-facial areas, they don't heal as well, again, because there's not hair follicles in the area, and it takes longer for that area to re-epithelialize. So when you're doing the neck and the décolleté, or even the backs of the hands, the skin's a lot thinner too. So you need to use a lower solution and do more frequent as opposed to really harsh. Microdermabrasion is not used as often anymore, but it was used to treat fine lines, pigment issues, acne scarring, and you need a series of them, but you can have them done every 7 to 10 days, and there's usually mild redness. Rarely does it last 1 to 2 days, but you can tell your patient if it's a really aggressive one that they might have redness that long. Microneedling is a PCI, percutaneous collagen induction, and it's to restore skin tightness, diminish fine lines, acne scarring, and stretch marks. It also helps with hyperpigmentation. It's really pretty good with pigment. What are the contraindications? If the patient hasn't used the pre-treatment with a retinoid, it's going to be difficult because you've got to go through a thicker epidermal layer, and you're not going to get as good of outcome if they've been pre-treated. Presence of skin cancers, warts, solar keratosis, or skin infections, active herpes simplex. Patients are on blood thinners or warfarin or heparin, which is obvious. You're going to be sticking needles in there, so you don't want them bleeding and have a difficulty stopping it. Allergy to local anesthetic. You want to put local on them when you're going to do this. So if they have an allergy to it, it's kind of hard to use it topical. I know you can get some of the over-the-counter ones if they're allergic to lidocaine, to get just a non-lidocaine one made at a compounding pharmacy. If they have uncontrolled diabetes, they're going to have wound healing issues, so you don't want to treat them. And obviously, if they have a history of keloids or stretch marks, less than 1 year. With microneedling, you need to prep the skin, and again, you need to use something to get the bacteria off there, so I would recommend using the hypochlorous or alcohol. Have them cleanse their skin. A lot of the makeups now, again, like I said, they stick and they're hard to get off. You can tattoo them if you don't get that makeup off them, so make sure you cleanse them really, really well. Get your pre and post pictures, and topical vitamin C and A 3 weeks prior, just to get their skin, just to have good health in addition to the retinoid. Here's the depths and the mechanism of action for the wound healing cascade, and it shows you in the number of days and weeks as far as the vasodilation and vasoconstriction, and then the the fiber cells and the epithelialization. And so phase 1 is micro injuries to the skin, and then phase 2 is the neutrophils are replaced by monocytes, and that's where the stimulation of the collagen elastin comes. And then phase 3 is the wound undergoes maturation. So it usually takes several weeks to see the outcome from the treatment, depending on the solution that you actually are microneedling in. You'll see results right away. Otherwise, let the patients know they're not going to see it tomorrow morning. Let them know that after the treatment they're going to feel like a sunburn or redness and swelling. But the depth of the treatment can go from 0.25 to 2.5 millimeters. I know some of the pens go to 3 now, but keep in mind when you're around the eye area that it's only 0.5, so you need to constantly be re-regulating the depth that you're going to go. Don't just set it on one setting and go, because you'll have a lot of bleeding, and your end point is pinpoint bleeding, not bloody. So the post-treatment care, again, is they need to avoid sun exposure 10 to 28 days. The day of, you do not want to put sunscreen on there, because it can actually go in those channels, and if those products are not meant to be intradermal, as in including anything that you're going to be microneedling in, you could cause a granuloma. There's a certain micron size that particles need to be in the dermis, and if they exceed those, you're going to stimulate the macrophages, and you could cause a granuloma just by microneedling. You do want them, though, to use the SPF the post-day, again, and let them know that they're definitely going to have inflammation. First day, most of mine look like a sunburn for one day. Then they'll peel in like up to about 5 days. They'll notice some peeling. And the fibroblast phase is between day 5 to 14. So they might start seeing a little bit of glow, but it takes, again, like about 3 months to really see some softening in the fine lines. So if they are going to be having any treatments again, you need to give them 30 days because a skin cycle is about 28 days. So if there's somebody that wants to do frequent microneedling and you've done packages for them, give them a 28-day lag between and do them like every 4 weeks. But they can do as many as they want. But generally it takes about 6 treatments to see a change, and it's really individual. You know, you definitely, you know, some people you may only have to do 4 treatments. Some, if they have really deep rhytids, may take a little bit more. Pigment is even harder. We did it. Ta-da! So, again, just a reminder that the test is 150 multiple choice questions. Make sure you give yourself enough time. It is a time test. I think that's the biggest thing you need to remember, especially if you haven't taken one in a long time. But there's my info. I think you guys all got it the last time, but if you don't have it, I'm flying home tomorrow, so if I won't be able to be contacted before the test because my flight's really early, but you can still email me up to tonight. I'll be good.